Hello, everyone. Welcome to Offbeat Medicine. All right, nice. I see everyone from all over the world. Nice. That is great. So today, what we're gonna do, we're gonna start endocrinology and try to finish physiology of endocrine, which is really high yield. If you know physiology, pathology is gonna be super easy because everything is deranged in pathology, and it's gonna be super easy. So let's just get started. And welcome everyone, whoever commented and whoever is there. Nice seeing you all here. Let's start. All right. Let's start with endocrine. All right. The first thing we have in endocrine is the thyroid development. In the thyroid, it's very high yield. Okay, very very high yield. So thyroid diverticulum arises from the floor of the primitive pharynx. This word here is really important itself. Primitive pharynx is a pharyngeal epithelium. Uh, okay, it's a pharyngeal epithelium. They might ask you, okay, what is, because they might not say primitive pharynx. They would say, well, where does this thyroid arise from? And that's the pharyngeal epithelium. And it descends into the neck. Okay, so taking a look here, so it starts, let's say here, and then it goes down to this point. And any point that it is traveling down there, it could stop. Either it could stop right here in the mid, and we will talk about all of that. I'm just giving you an overview right now. And if it stops anywhere, and that's going to be pathology. Okay, so right now we said thyroid diverticulum arises from the primitive pharynx, which is a pharyngeal epithelium, and descends into the neck, which is the interior of the neck. It is connected to the tongue. So let me erase a little bit of these things. It is connected to the tongue by thyroglossal duct, which normally disappears but may persist as a cyst. So this thyroglossal duct would normally disappear, but if it persists, it's going to be as a cyst, or it could make a pyramidal lobe of the thyroid. Two things. Again, if it persists, it's going to make a cyst, or second thing, pyramidal lobe of thyroid. Okay. Foramen cecum is normal remnant of the thyroglossal duct. And what is foramen cecum? It is the here is the groove in the tongue. So it's the normal remnant of this thyroid duct, thyroglossal duct. Okay. So most common ectopic thyroid tissue is the site is in the tongue. Lingual is known as lingual thyroid because, again, in the tongue, lingual thyroid. Now, some questions do come on this as well. So what is a lingual thyroid? So if you have a thyroid follicle, let me just draw it here. If you have a thyroid gland here, let's say, guess what's going to happen? Now you will have, and again, they will ask you, where is it? Most likely it's going to be at the base of the tongue. Base of the tongue is the most common site. And it's going to present as mass, large red lingual mass under the tongue, at the base of the tongue. Okay. And enlargement of this mass is going to cause what? Is going to, again, if you're trying to have a mass here, guess what you can have? You can have obstruction. So obstructive sign symptoms will be there. For example, dysphagia, dysphonia, dyspnea. 3Ds. Dysphagia, dysphonia, and dyspnea. Okay, and that's all about the lingual thyroid. And I'm going to read, okay, the way we do it, we read a page and then we go over this again. So, you could just listen, and then when we go over it, it's just going to review those details again, okay? So removal, if you were to remove this guy, which is a lingual thyroid, okay, it might result in hypothyroidism. Why? Because it might be the only thyroid tissue present. Okay, so that's there. And the next thing is thyroglossal duct cyst. So let's go back to the thyroglossal duct. This here, if it persists, we said it's going to be either cyst or the pyramidal lobe. So we're talking about cyst now. So thyroglossal duct cyst presents as an anterior midline neck mass, okay, that moves with swallowing, high yield, that would move with swallowing. You ask the patient to swallow, or maybe take a sip of water, and you will see that proper mass moving while they swallow, versus, or protrusion of the tongue will do the same, versus persistent cervical sinus, which is again an anterior midline mass, but it will not move with swallowing. Okay, so two differentials are here, and it's leading to the pharyngeal cleft cyst in the lateral neck. So it's a lateral neck mass. Okay, and it will not. Important thing is this: it will not move with swallowing, and that is going to be your persistent cervical sinus. Okay, and with this, just the thyroglossal duct cyst, it's an anterior midline neck mass which would move with swallowing. Okay, now the next thing is all about where they're derived from. The thyroid follicular cells, they're derived from the endoderm, while the parafollicular cells are derived from the fourth pharyngeal pouch. Okay, now some more important things are going to be, let's talk about those here, which is the blood supply and the nerve supply. So blood supply, fortunately, it's here, a nice red picture here. So all you got to know is, okay, you have a superior thyroid artery and an inferior thyroid artery. These two arteries are going to supply the blood to the thyroid and the parathyroid gland, right here. Now, where these arteries come from is totally different, because the superior thyroid artery is a branch of external carotid artery, right? And the inferior thyroid artery is a branch of, first of all, left subclavian gives out branch thyrocervical trunk, then goes into inferior thyroid artery. Okay, so just know there is a different blood supply, okay, for superior and inferior. Now, more important to that is that near the superior thyroid artery, we have something known as external laryngeal nerve. And near the inferior thyroid artery, we have the recurrent laryngeal nerve. So when we, let me zoom in here. Okay. So when we go into the thyroidectomy, doing a surgery, okay, you might cut down this nerve, which is the external laryngeal nerve, right? Or if you could also cut down this recurrent laryngeal nerve. Now the problem is you got to know which structures are supplied by what. So recurrent laryngeal nerve supplies all the muscles, everything of the every muscles. Like for example, posterior crico. Let me just actually write them. All muscles, for example, posterior cricothyroid. What else do we have? A lateral cricothyroid. Oblique arytenoid transfer. I mean, there's so many. That's all you got to remember is all muscle. I can just write them here. I'll just say them. Okay, you have a transverse arytenoids, oblique arytenoids, and thyro arytenoids, and posterior crico arytenoids, and lateral cricoarytenoids as well. So you have all these muscles. Now, what you got to know is only one muscle, which is total different. That's going to be your cricothyroid. What is it? Cricothyroid, right? Cricothyroid muscle. Yes, right here. Let me write this one down. Cricothyroid. So this one is important. Why? Because there's only one nerve. This whole nerve, external laryngeal nerve, is supplies this one muscle. Okay, and that's it. And the rest of all the muscles are supplied by your recurrent laryngeal nerve. So if you knock this out, guess what's going to happen is that's very high yield actually. If you knock this out, you're going to have loss of voice, and or obstruction to the breathing. Okay, but if you were to knock this external laryngeal nerve, all you are going to have is a low hoarse voice. Let's just get this here. Low hoarse voice with a limited pitch. Okay. So you can see the difference. Two nerves, total different things. So recurrent laryngeal nerve can get injured as they run near the inferior thyroid artery. Okay, as I mentioned here, inferior thyroid artery. External laryngeal nerve can get damaged as it courses with the near the superior thyroid artery and the vein. Okay, so this is there, and this is very high yield point. Okay. One more thing that I would like to mention here, since we are talking about these two nerves, recurrent laryngeal nerve not only supplies these muscles, but also it supplies the sensory sensations below vocal cords. Sensory sensations below vocal cords. Vocal cords. Okay, and if this recurrent is supplying below vocal cord, so you can right away think, okay, who's going to supply above a vocal cord? It's called supraglottic sensation. That's the external laryngeal nerve, which also supplies the supraglottic sensations. Okay, and that's going to be what we have. So let's just review this now. All right, in thyroid development, what we talked about, okay, we said, let's change color here. We said the thyroid diverticulum arises from the floor of the primitive pharynx, which is the pharyngeal epithelium, and descends into the neck. While coming in, traveling down, while it is traveling down to the neck, in this migration, it might just stuck somewhere. So it might stuck in the mouth, which is the base of the tongue, or it could stuck in somewhere. And all that is going to be, wherever it gets stuck, it's going to have that thyroid tissue there. So you will see a mass. So some of the mass are sublingual mass, prelaryngeal mass. If it gets stuck here, it's called prelaryngeal mass. And normal location is here, so normal is here. Normal location. Okay. So it's simple, right? But now we said, okay, it's connected to the tongue. It's connected to the tongue by this thyroglossal duct is connected to the tongue. Okay, and that connection where it starts is called foramen cecum, which is there is a depression on the tongue, and that's called the foramen cecum. Okay, which normally disappears. This whole duct would disappear. This whole duct would normally disappear. But if the remnant is there, it can be as cyst or pyramidal lobe of the thyroid. Foramen cecum is normal remnant. This is total normal. Second thing is most common ectopic tissue is going to be at the base of tongue, which is called lingual thyroid. But if you were to remove this, you can go into hypothyroidism. The cyst of the thyroglossal duct cyst will present as anterior midline neck mass, which would move with swallowing, versus persistent cervical sinus, which is going to be on the lateral side, and it will not move with swallowing. Okay. Thyroid follicular cells are derived from endoderm, while the parafollicular cells are derived from fourth pharyngeal pouch. Now, most important is this: in the thyroidectomy, if you were to cut on your superior thyroid artery, you could nick on the external laryngeal nerve, or inferior thyroid artery, the recurrent laryngeal nerve, and the recurrent supplies all muscles and below vocal cord sensations. If you were to knock this out, you're gonna have loss of voice with obstruction to breathing. And if you were to knock out the external laryngeal nerve, all you're losing is a limited pitch and a low voice. A low hoarse voice will be there, and it also supplies the supraglottic sensation. Excuse me. if you have any question up to this, you could always write in the chat and I'm happy to answer. Okay, I guess that let's move on then. Okay, now let's talk about pituitary gland. Pituitary gland has two things. It has an anterior pituitary. There are two things: anterior and a posterior pituitary. Right? Anterior A is called adenohypophysis or hypophysis. Posterior is called neurohypophysis. Okay, so as so the pituitary sits on the sella turcica. So here's the, let me just actually do that so it's easier to understand what I'm saying. So pituitary sits on a bone known as sella turcica. Sella turcica. Okay. And above pituitary, right on top of pituitary, all we have is called optic chiasm. Okay, let me just do this. Optic chiasm. Okay. And hypothalamus sits up top, hypothalamus, and you have fibers coming down from the hypothalamus to the pituitary. And this thing is called, these fibers or this circulation or portal system is called hypothalamic hypophyseal portal system. So let's just write it: hypothalamic hypophyseal portal system. Okay, so now with that, let's just talk about anterior pituitary. Anterior pituitary secretes FSH, LH, ACTH, TSH, prolactin, growth hormone, GH, beta endorphins. MSH, which is a melanotropin, secreted from the intermediate lobe of the pituitary, derived from the oral ectoderm, Redke's pouch. High yield. So anterior pituitary is derived from oral ectoderm, Redke's pouch. Okay. And alpha subunits, we have alpha and beta subunits. The alpha subunits, they have the hormone subunits common to TSH, LH, FSH, and HCG. While the beta subunits are, they determine the hormone specificity. Okay. That means that if you have a beta subunit, they specifically would tell, okay, that's the hormone. But now something you will see that even in the beta, there are some common beta subunits. For example, HCG and TSH, thyroid stimulating hormone, they have homologous beta subunits. Okay, that's one thing. So this allows, what's going to happen, this allows the HCG to bind and activate the TSH receptors. And that's going to cause, for example, if you have a lot of HCG, it's going to cause paraneoplastic hyperthyroidism. Okay, so that's the important thing. Other than that, you have, you should know that, okay, the alpha subunits are also common to TSH. Look at that. So you have a TSH at a beta HCG, right? So they're already there with the alpha subunit and also in the beta subunit. The only two that are left that you have to know is LH and FSH, nothing else, which is not that hard to remember. And that's going to be all we have here. On the right side, it says very important is the pro opio melanocortin POMC derivatives. So POMC derivatives are beta endorphin, ACTH, MSH. Go pro with the MAM. That's a mnemonic if you want to go with it. But if you don't want to go with it, just remember with ACTH, and we will talk about in pathology as well, that we have hyperpigmentations and all that. And why is that? Because of MSH being there. Okay, so with ACTH, you're going to think about there are two more things that ACTH just has. You have a beta endorphins, and you also have MSH. Okay. Now there's another mnemonic known as flat peg, which is the FSH, LH, ACTH, TSH, P, RL, and GH. Beta flat or B flat is the basophils, which are the FSH, LH, ACTH, and TSH. An acid peg, which are acidophils, acetophils, prolactin, and growth hormone. So just remember the prolactin and growth hormones. They are acetophils. Okay, and the other ones are just going to be the basophils, because there are only two here. So I guess it's easier to, memorize two than to memorize the whole thing. Okay. Now let's talk about the important thing. This was just a reading purpose, but let's talk about some important thing. So here's the red keys pouch, right? So this guy, this adenohypophysis, is derived from the oral ectoderm, right? Which is known as the red keys pouch. Red keys pouch. Now, in children, what's going to happen is something you will see if any remnant of the red keys pouch remains within this oral ectoderm, it can lead to formation of craniopharyngiomas. Craniopharyngioma. Okay, and this craniopharyngioma is going to be it's going to give you hypopituitarism and diabetes insipidus and hydrocephalus in a patient. So decrease in pituitary. Second thing is going to be DI. Third thing is your hydrocephalus. Craniopharyngiomas. So what is craniopharyngioma? Is the remnant of this red keys pouch that stays within the oral ectoderm. Okay, so that's pretty much what we have here. One last thing here is MSH. Sometimes they don't say MSH, they might say the full name, and the full name is melanocyte stimulating hormone. Let me just write it here. Melanocyte stimulating hormone. So melanocyte stimulating hormone. Okay, and that, as the name suggests, that's just going to stimulate melanocytes. And guess what? When you stimulate melanocytes, you're going to go increase melanin. So here is this. Increase melanin. Increase melanin is just like hyperpigmentation, and that is why when we have ACTH high, there will be hyperpigmentation seen. Okay, and what else we can think of? So all these hormones are regulated by hypothalamic releasing inhibiting hormones as they're secreted on the median eminence. So here, this thing. Okay, so these hormones are going to be regulated by hormones secreted by the hypothalamus. Okay, which work on the median eminence of the hypothalamus and act on the anterior pituitary via hypothalamic hypophyseal portal system. And one important high yield point about this portal system is this does not have blood-brain barrier. So it does not have BBB. Okay, no BBB here. Okay. Now let's talk about some hypothalamic hormones which are coming from top and causing the release of these hormones. So you have GnRH. So let's just write here. Actually, it might come up. Yeah, it's going to come up later on. So we'll just talk about that at that time, and then I might come back and take a look at this figure here. Okay, so it's gonna come up. So just let's read the next one here. It's called the posterior pituitary, which is the neurohypophysis. Now, important point with the neurohypophysis is this guy is a neuro, right? So it's going to be, it's going to derive from neural ectoderm. Neural ectoderm. So what is common? The common is ectoderm. Let me write this here. Ectoderm. Neural ectoderm. With the neuro being there or posterior pituitary being there, all you're going to think about, okay, neural ectoderm and oral ectoderm. Oral because it's coming from the oral cavity, evagination. So you have the oral cavity. There's a full-on evagination of the oral cavity, which is known as the Redke's pouch, which would go from here all the way towards the posterior pituitary and just join up there. And that's the normal anterior pituitary. While the posterior pituitary is straight up from the, coming from the hypothalamus, is a part of hypothalamus, which is the neuroectoderm. Okay, so ectoderm, remember ectoderm, and both are ectoderm, but one is oral ectoderm and the other is neural ectoderm. And that's important. So posterior pituitary, now here it stores and releases vasopressin, which is antidiuretic hormone or ADH, and oxytocin, only two things. Okay, vasopressin and oxytocin, both are made in hypothalamus. Okay, they're not made in posterior pituitary. They're all made in hypothalamus, supraoptic and paraventricular nuclei, and they're transported to the posterior pituitary via neurofissins. Now, guess what? If you knock out these neurofissins, you're going to have a problem, right? Because they're made up high in this hypothalamus. All they do is travel down through these neurofissins. If you knock them out, you're going to have a problem. We'll talk about that. So here, let's just, when neurohypophysins are carrier proteins, so the whole posterior pituitary is derived from the neuroectoderm. We talked about it. Okay, so here is the problem with the neurohypophysins. So let's talk about that now. So neurohypophysins, they are carrier proteins for both the oxytocin and the ADH. Okay, and they are produced by the hypothalamic nuclei. They bind to the oxytocin and ADH and shuttle them where? To the nerve terminals in the posterior pituitary. Now, now the problem is if you have because they bind to specifically each one of them. So if you have there's a problem known as autosomal dominant hereditary hypothalamic diabetes insipidus. All it is that you have a DI, diabetes insipidus, but that's because it's hereditary. So let's just write it. It's an autosomal dominant hereditary hypothalamic DI, diabetes insipidus. And why is that? Because when you have a congenital problem or when you have a genetic problem in the neurohypophysins, you are going to get, it's an autosomal disease, a hereditary, which will cause hypothalamic problem that will cause DI, diabetes insipidus. Why? Because you have a neurofissin 2, which specifically binds to ADH, okay, and it's involved in transport and packaging of this ADH through the ER and the Golgi apparatus into these granules. And if you have a point mutation, now important point is this called point mutation. There's a point mutation of neurofissins 2. And that is going to lead leading to this AD, autosomal dominant hereditary hypothalamic diabetes insipidus. And that is pretty much what we have as a pathology here. Okay, so let's take a look at the next thing. What do we have? All right, so now we have adrenal, cortex, and medulla, high yield. Again, just the names, the layers, how they are primary regulated high yield. Okay, so let's take a look. So adrenal medulla and cortex. Okay, so adrenal cortex, it is derived from mesoderm, and the medulla is derived from neurocrest. Again, high yield. Okay, and here are the layers. So you have a mnemonic known as GFR. Normally GFR is for the kidneys, right? But here it's a mnemonic. GFR corresponds with salt, which is the first layer, mineralocorticoids, sugar, glucocorticoids, and sex, which are the androgens. We're just talking about, remember, we're just talking about the cortex, not the medulla. Medulla is a whole different scenario. It's a whole different thing, right? We're just talking about the cortex. And this is the adrenal gland. And here's the cortex. And in the mid, you have this medulla, right? So let's look into this thing. So taking a look at this picture, this is also very high yield. So what do you see? You have a layer. You have a lot of cells. All you got to remember, okay, there are a lot of cells in the first layer, and you have less sort of, you can see through them. So less cells, and then again, there are more and more cells. And the last ones are just total out, the blue cells, right? So now you already know that the first one is going to be G, and the mid one is going to be F, and the last one is going to be R, and the very end is going to be medulla, which might they not ask, but these three, GFR, as for histology, important. Okay, so primary regulated. So that's very high yield actually. So GFR, the primary regulation is by angiotensin 2 for the G zone, or the zona glomerulosa, is the angiotensin 2. Now, when you stimulate this zona glomerulosa, the hormone they secrete is called mineralocorticoid. Okay, and the primary hormone produced by them are aldosterone. Now, what is the function of aldosterone? Just talking about here, simple thing, it increases blood volume. Just one thing right now. And we'll go into details later on. Just remember, it's just going to increase the blood volume by retaining sodium and water, and we will talk about that. But just keep in head, aldosterone is just going to increase the blood volume. Okay. For the next layer, we have this zona fasciculata. Fasciculata, there are two primary regulations. One is ACTH, the other is CRH. Now, if you recall something we will talk about again, is the hypothalamus sends off the CRH, which then leads to release of ACTH. Okay, so either the ACTH is directly going to stimulate this zone, or CRH is also going to do the same thing. And the hormones they're going to produce is called glucocorticoids, and the primary hormone produces the cortisol. Okay, and I'm just going through them right now, and we will talk about each one of them in a bit. Okay, so cortisol, just on top of that, you should know that, okay, it's going to do a couple things. It's going to increase the vascular tone, and it's going to increase blood sugars or blood glucose. With the name glucocorticoid, it's easy to just think, okay, sugar, glucose high. And again, the other thing is increasing the vascular tone. The last zone here, we have the zona reticularis. Here, again, it's the same thing, ACTH and CRH. And they are the primary hormone they produce is called androgen. Hormone classes androgens, and the primary hormone is DHEA. Okay, with the DHEA, the normal function you can think of is going to be your libido and hairs, pubic hairs in women, you can think of. Okay, just basic functions here. Okay, and let's talk about now the medulla. Medulla is blue, like chromaffin cells. Chromaffin cells are deeply basophilic. Okay, two things, okay? When we think about basophil, let me just write here. Basophil, eosinophils, Basal for blue. Just remember B for basal, B for blue. Eosinophils are pink. Okay. B for basal, B for blue, and others are pink. So here the chromaffin cells there are basophilic. Deeply, and why is that important? Why am I telling you all this, right? This is important because they're not going to say it's the chromaffin cells, it's the medulla. They say, okay, there's a problem. There are a lot of basophilic cells or deeply basophilic cells. They are there. What are those cells? Or so you should know the last medulla is just going to be total basophilic, nothing else. Okay, so that's why this is important. It's a deeply basophilic cytoplasm. And these guys are going to be regulated by preganglionic sympathetic high yield, preganglionic sympathetic fibers. So let's just talk about this one here. Now here, what am I saying? I'm saying preganglionic sympathetic fibers, but important point is these sympathetic fibers are going to release acetylcholine. Acetylcholine. So sympathetic fibers releasing acetylcholine, okay, which would stimulate these catecholamines. Now catecholamines they release are going to be epinephrine, norepinephrine, but high yield point is epinephrine is about 80% and about 20% is only norepinephrine. Okay, and these guys are just going to directly go into the bloodstream, and so directly is the important point because they're not going to go into the nerves, right? They're just going into the bloodstream, and directly they will stimulate the receptors on the blood vessels. Okay, so now important point, last point that I'm going to mention here, then I'll go through the whole thing, is that GFR, so all these three layers, G and F and R, they are all derived from cholesterol. So GFR, all these layers are derived from cholesterol. Okay, and that's going to be what we have. So let's talk about this, and then I'll talk about one pathology here. Okay, now let's read it and make it the way we can think and say, okay, we know it now. Okay, what do we have? Simple thing. Okay, adrenal cortex, medulla. All you gotta know is GFR, G and F and R. One thing for the first one is going to be angiotensin 2. The rest is the same. So G is the angiotensin 2, which stimulates it. And for the F and R is the same thing, CRH and ACTH in both, same, right? With the angiotensin 2, all you're releasing, if you just recall your RAS activating system, RAS, guess what? With the angiotensin 2, who are you activating? You're always activating aldosterone, right? So again, same thing. Angiotensin 2, or you could just go this way, okay? A for angiotensin and A for aldosterone. The first layer is just going to release aldosterone. Second layer is just going to release cortisol, which is a glucocorticoid. Maybe you don't even remember the names. If you want to remember, that's great. I mean, actually, by the time we get the end of this endocrine, you would know the names yourselves. Don't worry about that. But glucocorticoid is cortisol. And the last layer is DHEA, which are the androgens, sex hormones, right? Okay. And the medulla is just the catecholamines, which are epinephrine and norepinephrine. Now, high yield with the medulla is going to be sympathetic fiber stimulating it, which is going to be these sympathetic fibers. They are not going to release norepinephrine or anything else, but they will release acetylcholine on this medulla. Okay. Now, one point that is a high yield is called, if you have a low ACTH, so let's just do it here. If you have a low ACTH, now guess what's going to happen? So if you have a low ACTH, you're not going to stimulate your fasciculata. You're not going to stimulate your reticularis. So let's just do it here, GFR. These two cortex layers will not be stimulated. So you will go into atrophy. If you have a low ACTH, atrophy of fasciculata and reticularis. Why? Because the growth of the granulosa is not based on ACTH, it's based on angiotensin 2 stimulation. Because the growth of, again, granulosa, the first G is stimulated by what? a angiotensin 2. So that's total normal. The only thing which is going to go into atrophy is these two layers. And that's an important thing. And that's going to be all for this adrenal cortex and medulla. Moving on with this endocrine pancreas. Let's change color. So pancreas cell types, right? So islets of Langerhans are collections of alpha, beta, and I guess delta endocrine cells. Islets arise from the pancreatic buds. Okay, so alpha is glucagon, which is in the periphery. The easy way to go for it is just remember, you have alphas here. Okay, in the center, you can just say beta cells, right? And last thing is interspersed within them are just your delta. So let's just change color and call this these guys, which are your somatostatin delta cells. So again, alpha glucagon, which is in the periphery. Okay, beta insulin, which are central, as you can see here, and somatostatin, which is interspersed delta cells. Okay. And that's pretty much what we have here. Let's move on to the next. Okay, now we're talking about the hypothalamic hormones. Okay, hypothalamic pituitary, actually everything. Hypothalamic pituitary hormones ADH, antidiuretic hormone. Antidiuretic hormone, the function is to increase the water permeability of distal convoluted tubules and collecting ducts cells in the kidney to increase water resorption. Maybe just right now remember that they would increase water resorption. Where are they working? DCT, distal convoluted tubule, plus CT, and collecting ducts in the kidney. And all they're causing is antidiuresis, right? Simple thing, antidiuresis, meaning no diuresis, meaning trying to conserve the water, so increase water resorption, right? Clinical note here is the alcohol consumption would decrease ADH secretion. When you decrease ADH secretion, guess what? You're not trying to conserve that water, so you're going into polyuria. When you're doing polyuria, a lot of urine is going out, causing dehydration. So alcohol leading to dehydration. The next is CRH. CRH, the function is going to increase ACTH. And again, when you, it's the whole POMC, remember? So when you increase this CRH, it's going to stimulate the POMC. And POMC has all these three things. It has ACTH, it has MSH, and beta endorphins. So CRH is going to stimulate the POMC, and this POMC would stimulate all these three things. Okay, now what is CRH? CRH is corticotropin releasing hormone. So corticotropin releasing hormone. Okay, and this is decreased if you give a patient chronic glucocorticoid. If the patient is on a chronic glucocorticoid therapy, the whole axis is down, so the whole CRH is going to be down. Okay. And the next is prolactin inhibiting factor, which is PIF. Again, prolactin inhibiting factor, right? So it's going to, as the name suggests, it's going to decrease prolactin. But not only that, but also it decreases TSH. Okay, so commonly referred as dopamine. So this thing that is the same thing as dopamine. Dopamine antagonists are going to be antipsychotics. They can cause galactorrhea due to hyperprolactinemia. Again, if you're knocking out your dopamine, if you're trying to inhibit this dopamine, so normal thing is dopamine normally is inhibiting prolactin release. That's normal. You knock this dopamine out, or you inhibit its, you give an antagonist of dopamine, you will not be able to stop prolactin. So prolactin is going to be high. When the prolactin goes high, you're causing galactorrhea due to hyperprolactinemia. And we will talk about that in prolactin. It's going to come up in a bit. The next is GHRH. GHRH with a bigger H, right? This is going to be growth hormone. Growth hormone. Releasing growth hormone, releasing hormone, RH. This is just going to cause increase, as the name suggests, is going to cause increase in growth hormone. With the growth hormone analog is tesamorelin, however you call it. It is used to treat HIV-associated lipodystrophy, high yield. Okay. So instead of calling it tesamorelin, you just think, okay, HIV-associated lipodystrophy is going to be treated by Tesla Morlin. You want more Teslas, okay? Tesla Morlin. Or if you just remember Tesla More, I mean, the lin is just going to be there. If you have a Tessa More or Tesla More, it is for HIV-associated lipodystrophy. I mean, if you have a better mnemonic, great. Feel free to, share it with us. And the next thing we have is called GnRH. GnRH is simple. It's it's gonadotrophin regulating hormone. Now, high yield point with this guy is going to be that it has to be pulsatile secretion. Pulsatile secretion. And that the pulsatile secretion from the hypothalamus is going to cause increase in FSH and increase in LH, only the pulsatile secretion of it. Okay, so it's going to stimulate the anterior pituitary, cause increase in FSH and LH. And just to recall something, so what is FSH going to do when you have increase in FSH? Well, that's going to work on your Sertoli cells. And Sertoli cells are going to produce something known as androgen binding protein locally. Okay, that's important. So androgen binding proteins, but important point is locally. And why locally is important? Because locally, they're responsible for high local testosterone concentration, because these guys will bind to the testosterone and keep it there, not let it go into the blood and cause all its effects. So locally increasing androgen binding protein will cause more and more binding of testosterone, and locally increasing testosterone concentration and FSH are necessary for spermatogenesis. Okay, that's important. The other thing that these guys do, Sertoli cells, they also release, and this is going to come up in reproduction, but here's just a overview of how things are going to work. So again, if you're giving GnRH, it's going to stimulate this. It's going to make all of this, and it's going to have more and more testosterone locally, right? But now the problem is we don't want a lot of testosterone there. We have to have some inhibiting factors. So this is so these Sertoli cells not only produce this, but they also produce called inhibin B. They also release inhibin B, as the name suggests. Inhibin, just remember this is going to inhibit. Inhibin will go back and provide a negative feedback to the anterior pituitary to say, hey, we have a lot of FSH already. We don't want more. So inhibit the anterior pituitary release of FSH. Okay. And that's with the FSH. Now, quickly, let's talk about LH. Well, the LH is going to, with the L, remember L for Leydig cell. Leydig cells. These guys are going to actually release the testosterone now. Okay. And that testosterone, okay, itself is going to produce a negative feedback towards two things now. And not only is going to inhibit that anterior pituitary, but also is going to say, hey, I'm going to go to your master hypothalamus. I want no testosterone in the body. Okay, I have enough. I want to give a negative feedback. I don't want anything. Okay, and it's going to give two negative feedbacks. Okay, uh, that's all about this FSH and LH. Again, recalling the whole thing, FSH is all about what? Here we go. So FSH is all about, what is that? Give me 1 second. I have to erase this part. All right, so FSH is going to be all about going to the Sertoli cell, release of androgen binding proteins, which will locally keep that testosterone in a higher concentration. And why is that important? For the spermatogenesis. Sertoli cell will also release inhibin B, which would inhibit the release of FSH. And the other thing we have for the LH is going to stimulate the Leydig cell, and that will lead to release of testosterone. That testosterone will go and inhibit not only the anterior pituitary, but also its master, which is hypothalamus. Two negative feedbacks. Okay. So moving on to the next thing, what do we have? It's called, okay, let's do one thing here. So it is suppressed by hyperprolactinemia. Okay. Tonic GnRH analog, which is leuprolide, suppresses the hypothalamic pituitary gonadal axis. So tonic analog, which is leuprolide, would suppress this whole axis, which is hypothalamic. From the hypothalamus, you have the pituitary, and then you have the gonads. The whole axis will be suppressed. Okay. Now, if you were to give a pulsatile GnRH, would lead to puberty and fertility. Okay. So that's what we have. Again, as we said, pulsatile is the one which would stimulate these. And if you give a tonic or long-acting, leuprolide is actually a long-acting GnRH, and that shows the body, okay, this is like continuous GnRH being there. So that is going to suppress the whole axis. Well, if you were to give us pulsatile, a drug that is, or pulsatile GnRH would lead to actually increase in FSH and LH. That would lead to puberty and fertility. Okay. The next here we have the MSH. MSH is again melanocyte stimulating hormone, melanocyte stimulating hormone. This increases the melanogenesis by melanocytes, increasing causing hyperpigmentation, right? Causes hyperpigmentation in Cushing disease, where you have increase in ACTH, right? As MSH and ACTH share the same precursor molecule, which is POMC. POMC-BAM is a good morning, actually. Let's just do it here. POMC-BAM. Let me write here, okay? So we said POMC-BAM. So B for beta endorphins, A for ACTH, M for MSH. But on top of it, I mean, if you know a little bit what we should talk about in Cushing disease, you will right away tell, okay, the ACTH is always increasing, MSH causing hyperpigmentation. Okay. Now the next thing here we have this oxytocin. Oxytocin causes uterine contraction during labor, responsible for milk let down reflux in response to suckling. Okay. But also it modulates fear, anxiety, social bonding. Okay. Mood and depression. And that is what we have. When you increase secretion by, so oxytocin, increased secretion occurs when there is a stretch to the cervix. Okay. And also with the suckling, it increases. So suckling at the lactating breast would increase oxytocin. And when you increase the stretch of the cervix, when there's a stretch to the cervix, let's say in labor, it's going to cause increase in oxytocin. Okay, that's there. So modulates all that we talked about it. Great. Now, one thing which isn't mentioned here, you can also think about the analogs are used. So analogs of oxytocins are used for induction of labor, or to introduce labor. Okay, induction of labor, or to introduce labor. Okay, and in response to suckling, what they are doing is these oxytocin will work on myoepithelial cells in the breast. That's important. Myoepithelial cells. These are contractile muscles. These will contract, leading to milk letdown. So myoepithelial cells in the breast. Now, looking at prolactin, which is again known as PRL, it would decrease GnRH and also would lead to stimulates the lactogenesis, which is basically saying milk production, right? So again, if you think about it, milk is produced by prolactin, but it will not let down, meaning you will not go into lactation unless there's oxytocin there. Although milk is produced, not going down because no oxytocin. Okay, two important concepts. So pituitary prolactinoma now, when you have a lot of prolactin, with this adenoma being there, is going to cause amenorrhea, osteoporosis, hypogonadism. Why? Because it's decreasing GnRH. And galactorrhea. Why galactorrhea? Because this it's not in a normal physiologically high prolactin. It's just it's a pituitary adenoma, prolactinoma, right? So it's going to cause galactorrhea here. But breastfeeding will lead to increase in prolactin. Breastfeeding, normal physiological breastfeeding will cause increase in prolactin, and it will lead to decrease in GnRH, which will delay the postpartum ovulation, which is natural contraception. So sometimes you will see that the prolactin is a natural contraception. Why? Because when you have increase in prolactin, okay, in the breastfeeding woman, that's going to cause decrease in GnRH. When you decrease GnRH, you're decreasing FSH and decreasing LH. When you decrease FSH, LH, you don't have ovulation. So that is the natural contraception. Okay, the next one here, we have this somatostatin. Somatostatin there are a couple names to it right here. GHIH, which is growth hormone inhibiting hormone, right? So remember, GHIH is also known as somatostatin. Okay, this guy, as the name suggests, this is growth hormone inhibiting hormone. So it's going to inhibit that growth hormone, causing decrease in growth hormone, and also going to cause decrease in TSH. Okay, and I'll talk about the odds, which are the odd things here. Decrease in TSH is done by here and also here, and we'll talk about that in a bit. So somatostatin GHIH, there is an analog known as octreotide, which is also a somatostatin, which is also a GHI, but this is a analog, right? You could give it from outside as a drug. Okay, the next thing we have is TRH. TRH is thyrotropin releasing hormone. Okay, and that is going to increase TSH, and that will cause increase in prolactin. Increase in TRH, which is thyrotropin releasing hormone, example in primary or secondary hypopituitarism, may increase prolactin secretion. Why? Because when you increase this guy, it's going to, when you have this TRH, it's going to stimulate the prolactin release, and for sure you're going to go into prolactin secretion, causing galactorrhea. Here's a schematic diagram here. You can see a basophil, again, basal blue. Blues are going to be your your CRH, GnRH, and TRH. Well, for the eosinophils, which are eosinophils, which are pink. Here we have GHRH, dopamine inhibiting the prolactin and all that. Okay. So now let's revise this quickly and move on to the next. Here it's a simple thing, not but very high yield. You got to know the normal physiology, right? So here the ADH is all about increase in water resorption, right? And alcohol, what's going to happen is you're decreasing ADH, causing polyuria, leading to dehydration. CRH is corticotropin releasing hormone, which will stimulate the POMC, which will lead to increase in beta ICG, not beta ICG, but ACTH, MSH, and increase in endorphin. Glucocorticoid use is decreasing CRH. Prolactin inhibiting factor will for sure inhibit prolactin. Just remember this: whenever you have a prolactin now, if the something is stimulating prolactin, TSH will also be stimulated. For example, here, if something is inhibiting prolactin, the TSH will also go down. We will see that in prolactin how that is working. But here, just remember on top of your head, okay, TSH is correlated with the prolactin. So prolactin inhibiting factor, PIF, is inhibiting prolactin, so it will also decrease TSH. TRH is stimulating TSH, right? So it's also increasing prolactin. Okay. Now GH again is growth hormone, the bigger H, right? Growth hormone, releasing hormone, increasing GnRH. Within N, it's the gonadotrophin, so increase in FSH, LH, MSH, melanocytes, increase in melanocyte oxytocin, contraction, uterine contraction, and milk letdown reflux by suckling. Prolactin, milk production, which is lactogenesis, and decreases GnRH. Somatostatin, which is octreotide or GHIH, and that is just going to decrease the growth hormone and also decreasing the TSH. So this is a TSH being low with the growth hormone, but not high with the GHRH. So a little different thing here. Other than that, that's pretty much it. Now let's move on to the actual details of each hormone. And before we do, how about if we take a 5 minutes break, I guess, and then we knock these down. Growth hormone and its pathology coming up very quickly. So let's just take a 5 minutes break. I'm going to put the timer up and we will be back in 5 minutes. And while in that period you have any question, you can always write down in the live chat and I'll be happy to answer anything. Okay, welcome back, guys. Let me put back that screen. Okay, great. Here you go. All right, let's start with the growth hormone. Growth hormone. Do one thing here. All right, let's talk about now the growth hormone. Now, the growth hormone is the other name for growth hormone is going to be somatotropin. So let's just write that down here. Somatotropin. So a lot of somato, right? And we will differentiate how the names are different. So for example, somatotropin is a growth hormone, while somatostatin is the octreotide, which is inhibition of the growth hormone releasing hormone. So somatostatin versus somatotropin, important thing. Or the other name for growth hormone is going to be pituitary somatotrophs. Pituitary somatotrophs. Okay. So that's important. Next thing is, as I mentioned, also called somatotropin, secreted by anterior pituitary. You already know that. It stimulates linear growth, high yield, and muscle mass through the IGF-1, which is insulin-like growth factor 1. Insulin-like growth factor 1, which is known as somatomidin or somatomedin. I don't know how you want to call it, but somatomidin C. So let's just write that down here. Where is it? Somatomidin C. Okay. It is secreted by liver. So this guy is secreted by liver, IGF-1. Now it is released in so growth hormone is released in pulses in response to GHRH. Secretion is increased in deep sleep, hypoglycemia, stress, puberty, and exercise. So all these conditions, I mean, think about it. Hypoglycemia. So think about a child. Think about a child who's not going into hypoglycemia. I mean, this is one of the factors. For example, he's eating all the time. So growth hormones not released. I mean, it is released where in the sleep, in the stress, in the puberty, and exercise. So a child who has obesity, eating all the time, is not going into hypoglycemia, is not exercising. So the only factor which is going to release that growth hormone in a child is either the deep sleep or the stress, which a child might not get into stress, or it might go into stress, who knows. But deep sleep is the only thing. So with obesity, the linear growth of a child, muscle mass of a child, what about the linear growth, bone growth, the height of a child? So sometimes we think the food, the more we eat, the more we're going to grow. Well, that's not the case physiologically. I mean, as far as right now we can think of course, there's going to be a lot of papers on it. So we're just trying to, think more and more, dive into some discussions here, right? So hypoglycemia, wow, I mean, this amazes me all the time. Okay, hypoglycemia causing growth hormone, causing increase in linear growth of a child, having a more heighted child. Wow, amazing. But next we have the secretion that is decreased by secretion decreased by aging for sure. I mean, with aging, decrease obesity. See, here you go, obesity. We were talking about this hyperglycemia. We were talking about it right now. Obesity, hyperglycemia, and for sure somatostatin, which is octreotide, and the somatomidin, which is the regulatory molecule secreted by the liver in response to growth hormone acting on the target tissues. So this guy, IGF-1, which is insulin-like growth factor 1, is going to give a negative feedback to two things: anterior pituitary and to his boss, which is the hypothalamus. They're like, it's the same thing as what? As testosterone. because it's giving two negative feedbacks. Growth hormone itself is giving two negative feedbacks, same thing as testosterone. So why am I keeping these previous discussions here? So we know, okay, three things doing the same, almost this similar way of negative feedback. Okay. Then we have this thing called excessive secretion of growth hormone, which is also a problem. For example, in pituitary adenoma, may cause acromegaly in adults and gigantism in children. In children, it's going to be gigantism. In adults, it's going to be acromegaly. Can't fit the head size. The ring is getting shorter. The hands are getting bigger. The voice tone there's deep voice tone. Joints problem. Adults. In children, they're just big, humongous. Okay, because there is no fusion of this epiphyseal bone plates. We'll talk about that when we see growth hormone pathologies. But treatment-wise, we have, again, what we want to give is we want to give growth hormone inhibitor, so somatostatin analog, like octreotide or surgery, that could be as for the treatment. So let's take a look at this now. Here we have sleep, hypoglycemia, stress, puberty, and exercise would stimulate growth. This is hypothalamus. It would stimulate the release of GHRH, growth hormone releasing hormone, which is going to stimulate the anterior pituitary. And anterior pituitary is going to secrete growth hormone. Simple. Right? Now, that growth hormone does a lot of things. Now, there is a question now. What does it do directly and indirectly? So directly is going to the adipose tissues and to the liver. Okay, that growth hormone directly is stimulating the liver to produce IGF-1, nothing else. And in the adipose sites or adipose tissue, it's increasing lipolysis and decreasing glucose uptake. Okay. So when you say it's decreasing glucose uptake, that means that you will have increased glucose in blood, right? And that is known as diabetogenic. So this hormone is also known as diabetogenic hormone, okay? Because it's increasing blood sugars, increasing glucose in the blood. It is also known that it is anti-insulin. Why anti-insulin? Because it's keeping the sugars in the blood, while the insulin, the main function of insulin is, the only function for the insulin is to put that sugar back from the blood into the tissues, in the peripheral tissues. That's insulin. But when you're anti-insulin, you're trying to keep that sugars within the blood. So it's a diabetogenic, it's anti-insulin. Okay. Okay, so that's what we have. Okay. And then this is the main function, right? Not the main function, but this is the direct function, I should say, right? A direct function of growth hormone is on adipocytes, causing increase in lipolysis and decreasing glucose uptake, anti-insulin effect, and IGF-1 secretion. Now let's talk about IGF-1, which is the major thing here. So majorly is going to work on bone and on the muscles. On the bone is going to cause every single thing increase amino acid uptake, increase protein synthesis, increase DNA, RNA synthesis, increase chondroitin sulfate, increase collagen, increase cell size and number. Now, the major thing is you need to know is increase in linear growth. That's it. Increase in linear growth. And whenever you see anything increase, decrease, everything is increased by the IGF-1, right? And that's when you increase the linear growth, that's called a pubertal growth spur. Pubertal growth spur. Okay. And stimulate the chondrocytes in physis, epiphyseal growth plate. Okay. It also stimulates, which is mentioned here, chondroitin sulfate, and also stimulates this chondrocytes. Chondrocytes in the physis, which leads to epiphyseal growth, increase in epiphyseal growth plate, which gives you the increase in linear growth, which is the growth of the bone. Okay, so that's for the linear growth through the bone. Now let's look at when you're increasing the bone, you also want to increase the muscle mass, right? So it's going to cause increase in muscle mass. One word, increase in muscle mass. How? By increasing protein, for example, increasing protein synthesis and increase in amino acid uptake. You take up amino acid, you cause them to increase protein synthesis. So that is going to increase a lean body mass. Lean body mass. Also increases organ size. Organ size. Okay. So in the muscle, you're increasing lean body mass. In the organs, you're increasing the organ size. So that is what we have. And that is pretty much it. Now, some other things are, one thing that you have to know, which is not here, that is going to be, so you have, and let's just draw it like this. So you have insulin on one side, which wants to, take out that glucose from the blood and put it in the periphery. While there are other hormones, counter-regulatory hormones. These counter-regulatory hormones, they are just going to increase. They want to have the glucose within the blood. And what are those hormones? Those hormones are your growth hormone, your glucagon. You also have your epinephrine, and you have cortisol. So all these hormones, look at the level of insulin. I mean, insulin is only one versus like 4, 5. Amazing. Wow. And these guys, if they come into the bloodstream, they want the blood to have that glucose. And that's why they're called diabetogenic anti-insulin hormones, as they will increase the glucose within the blood. So the question is how they do it. Let's talk about that as well. So they increase blood glucose by increasing gluconeogenesis. So let's just put it here. Increasing in gluconeogenesis, meaning formation of more and more glucose. Neogenesis, right? By increasing in glycolysis or glycogenolysis, to break down that glycogen and to have that glycogen back into the bloodstream, causing more glucose in the blood. Glycogenolysis. Two things, right? Other things are increasing lipolysis. They're like, hey, fat, we need to cut you down. We want to have everything within the blood. There's a party going on, right? Everything in the bloodstream, lipolysis, lipolysis, right? The next thing is ketogenesis. With a lot of that fat in there, you also have ketogenesis going on. Formation of ketone bodies. So look, you have more and more glucose. On top of that, you have ketogenesis there, thanks to these counter-regulatory hormones, growth hormone, glucagon, epinephrine, cortisol. Okay, and that's pretty much what we have. Now let's talk about last point. Let's just erase this point. And that is about growth hormone. So we talked about access, right? We said growth hormone access, adults acromegaly, gigantism in children. What about deficiency? If you have a growth hormone deficiency in a child, it's called dwarfism. Dwarfism, which is failure to growth, right? Short stature and delayed puberty. Short stature and delayed puberty. That's within a child. Now in adults, what you're going to have is this growth hormone, that you will have increase in fat. And why do you have increase in fat? Because remember, growth hormone was doing lipolysis, breakdown of fats. So when you don't have a growth hormone, which was breaking down the fat, now you have a lot of fat, increase in fat, right? And that increase in fat with low muscle mass, so decrease in lean body mass, known as, now you will have called it central obesity. Central obesity is there, right? So for the adults, for the treatment wise, for the whole growth hormone deficiency, treatment is going to be, your synthetic growth hormone. You just want to get from outside synthetic growth hormone, and that should treat the problem. And that is all for growth hormone. Let's just quickly go over this and move on to the next. Okay, so growth hormone, simple. Growth hormone is going to be, first of all, got to know the names, right? Growth hormone, also known as somatotropin. Remember, you have a tropin and you have a statin. Statin is inhibition, while tropin is the same name. And midin is IGF, which is here. Okay. It is released by anterior pituitary. It stimulates the linear growth and muscle mass through IGF. IGF, look, linear growth, muscle mass. Increases insulin resistance, diabetogenic. We talked about it like in depth, how it is insulin resistant, diabetogenic. Release in pulses, anything pulsatile will stimulate the growth hormone, but if you give it continuous, it will not stimulate growth hormone. So pulsatile response of this GHRH coming down will stimulate and release of growth hormone. Secretion is increased in sleep, hypoglycemia, stress, puberty, exercise, and secretion would decrease with aging, obesity, hyperglycemia. Now, somatomidin, which is going to be a regulatory hormone, is going to inhibit the secretion, and growth hormone itself inhibits its secretion. And IGF-1, which is insulin-like growth factor, comes from liver. So guess what? If you have a liver problem, let's say there's cirrhosis or something, you will not be able to make IGF. And there's going to be a lot of fat deposition. Fat, why? Because you don't have lean mass. So only fat is there, central obesity. Okay. Excess secretion of GH, for example, in adenoma, pituitary adenoma, will give you acromegaly if in adults, and gigantism in children. Treat by inhibition of that GH or by surgery, remove that adenoma. While in deficiency in a child, you will have dwarfism, and in adult, you will just have central obesity with increased fat content. Increase in fat is going to be increase in LDL and increase in cholesterol. Okay, and that is pretty much it for growth hormone. Okay, one more thing, my bad. Last thing, actually, very high yield. How does it stimulate in the liver? That's through the JAK-STAT pathway. To the JAK-STAT pathway. So growth hormone works through the JAK-STAT to release IGF-1, which is somatomidin, which is in the middle. Midin, just think about it that way. C, okay, and nothing else. Let's move on with the ADH. ADH, also known as vasopressin. The source of this ADH is synthesized in the hypothalamus, in the supraoptic and paraventricular nuclei, stored and secreted by the posterior pituitary. So it is made where? Again, important thing is hypothalamus, but it is stored where and secreted from the posterior pituitary, not made in posterior pituitary, while the other hormones are made in the anterior pituitary. Okay, the stimulation comes from hypothalamus, but they are made here in the anterior pituitary. This guy and the oxytocin are not made here. They're made in hypothalamus. Okay, function-wise, it regulates the blood pressure. Why the V1? So there are two receptors, V1, V2. For the V1 as the one for the blood pressure, and V2, there are two L's, so osmolality, right? Primary function is serum osmolality regulation. ADH decreases serum osmolality, increases urine osmolality. Again, simple thing. We will talk about that. Okay, let's read first. While regulation of aquaporin channels, insertion in the principal cells of the renal collecting ducts. Okay, so is there a picture here? No picture. Great. All we have is a V1. Remember, 1 for 1L for blood vessels. V2, 2 L's for osmolality, right? Why? Because it's going to insert that aquaporin channels in the principal cell, causing to draw more and more water, reabsorbs more water, and that is going to decrease. That when you increase the water content in the blood, that is going to decrease the serum osmolality. When the water content in the urine is low, this urine osmolality is going to be high. That's what it's mentioned there. So decrease serum osmolality, increase in urine osmolality. Simple, right? ADH level is decreased in central diabetes insipidus. Uh, Again, ADH level is decreased in central. Central means coming from top. There's low ADH because you have a problem in the either hypothalamus or in the those neurophysians anywhere along the line of the brain. So you have a central problem, and that central means you have low ADH. Normal or increased level in nephrogenic. Nephrogenic means you have a problem in the kidney. Either they're resistant, either something is wrong, it's not working. So you have increase in ADH, but they're not working, meaning you have a kidney problem. So that's going to have an increase in ADH. But both are going to have this diabetes insipidus because in central you're not making enough, or you have a problem in the formation, in the making, in the production of ADH, while in nephrogenic you have the problem in the kidney, so there is no working of ADH on its receptors. So in both cases, both are causing DI, which is diabetes insipidus, but the only difference is in one you have in central you have you have decreased ADH because you can't produce it, while in nephrogenic you have more or normal ADH. So that's ADH is a different thing that you have to think of. Now desmopressin ADH analog is a treatment for central DI and nocturnal enuresis. Okay, again, desmopressin ADH. When you give ADH to a patient, guess what's going to happen? You're reabsorbing water. When you're reabsorbing water, they're not going to go into diuresis. So a nocturnal enuresis is bedwetting, so you will not go into bedwetting. Okay, because more and more water is reabsorbed. Simple as that. But you got to know the drug, which is called desmopressin, ADH analog. Vasopressin is a potent vasopressor that can be used to increase organ perfusion in septic shock. Okay, septic shock, vasopressin, you want to have a vasoconstriction, so you have more and more organ perfusion. You can use it in septic shock. Okay. So with this, let's talk about one thing, which is when it acts on these blood pressure V1 receptor, that's going to cause. Okay, one thing. Wait. Before we talk about that, let's talk about desmopressin here. Desmopressin is specific to V2 receptor only. So it has no function on V1 receptor. When it has no function on V1 receptor, guess what's not going to happen? You will not see a vasoconstrictive effect of V1 receptor stimulation. So there is going to be no vasoconstriction. So when you have no vasoconstriction, there is going to be no effect on blood pressure, on BP. So again, desmopressin, V2 receptor, selective V2 receptor agonist. It's also known as desmopressin, also known as DD. Let me write it down. Desmopressin, DDAVP. Okay, it is selective V2 receptor, and it is selectively going to work on these V2 receptors, which are in the principal cells of the renal collecting ducts, increases in the aquaporin channels, and that when you increase those aquaporin channels, you are going to reabsorb more water. And when you reabsorb more water, you will have a low water in the urine. That's going to cause increase in osmolality of the urine. And when you're reabsorbing water, you will also that water is going to into the serum, causing low serum osmolality, because that water is diluting this serum. So here's those two things. What else we can think of here? Let me see if there is anything important. Yeah, one more thing is going to be how they're working, which is again a high yield. So V1 and V2, right? So V1 would activate. So when the ADH stimulates these V1 receptors, it has to activate IP3 calcium, IP3 and calcium uh, messenger system. So IP3 calcium messenger system, which leads to, again, when you increase the whole thing, the endpoint is going to have increase in calcium, and that is going to cause smooth muscle contraction. So arteriolar, let me write it down, arteriolar smooth muscle contraction. When you stimulate that smooth muscle contraction, you're going to cause increase in blood pressure. Okay. And that's with the V1. Let's write about the V2 now. V2, on the other hand, activates adenylate cyclase. So activates AC, which is going to increase cyclic AMP. And that increase in cyclic AMP causes the insertion of those aquaporin channels in the principal channel in the renal collecting ducts. And that causes water reabsorption, which leads to, again, decrease serum osmolality and increase urine osmolality. Simple. Let's talk about now the regulation. Regulation of ADH is done through plasma osmolality and hypovolumia. So plasma, as you increase the plasma osmolality, it stimulates. So actually, let's read this here from this picture. When you increase the serum osmolality or decrease the volume in the serum, so hypovolumia, but the primary is again the osmolality, okay? So when you do that, that's going to stimulate hypothalamus. That is going to cause the release of ADH. ADH through the storage point, which is the posterior pituitary, gets released into the bloodstream, causes medullary collecting duct aquaporin channels. Again, we calling it medullary because they're in medulla, and they're the principal cells of the collecting ducts. And that is going to cause more and more water reabsorption, and that is going to cause decrease in urine volume, and with that you will also have increase in urine osmolality. Because you're absorbing water, again, it's going to increase the serum volume and it's going to decrease serum osmolality, and this guy would also inhibit the release of ADH. So high yield points are going to be your plasma osmolality and hypovolumia, but primary again is the osmolality. And that is going to be all for ADH. Let's quickly review this. In ADH, we talked about it's known as vasopressin. The analog is going to be desmopressin or DDAVP. It is selective for V2 receptor. So there are V1, V2. V1 is blood vessels causing arteriolar contraction, causing increase in blood pressure, while the V2 is for the osmolality. Because the primary regulation, the question is, why is ADH secreted? Well, the ADH gets secreted when it gets stimulated when there is increase in osmolality. So the whole job of ADH is to decrease that osmolality, serum osmolality. And it does that by coming and going into the kidney, causing aquaporins, causing the insertion of those aquaporins, which lead to increase in water reabsorption, and that causes decrease in serum osmolality, and that would eventually inhibit that ADH secretion. And that is all for ADH. Any questions on ADH? If you have, you can always let me know. And feel free to have some snacks, some water, some coffee, tea, anything. You know, let's go for a prolactin now, I guess. Okay, great, Dr. Alejandro. Great, man. Amazing. I'm also sipping on water and coffee here. But okay, let's let's go with prolactin. All right, now let's talk about prolactin. Prolactin, other names are going to be again uh, going to be pituitary lactotrophs. Okay, um, let's look at the source. Source is mainly bind to pituitary, right? Structurally homologous to growth hormone. So again, it is structurally homologous to a growth hormone. Function of the prolactin is to stimulate milk production in breast, inhibit ovulation in females, and spermatogenesis. And in males, oh my bad, spermatogenesis in males by inhibiting GnRH synthesis and release. So two things. One, it's causing milk production. Second thing, it is decreasing GnRH, which leads to inhibits ovulation and inhibits spermatogenesis. Ovulation in females and spermatogenesis in males. Two things, right? So, but when you have an excess amount of prolactin, which is associated with when you have an excess prolactin causing galactorrhea, amenorrhea, infertility, osteoporosis in females, gynecomastia, uh, again, infertility, decreased libido and input. Okay. So infertility, decreased libido and impotence in males. Well, in females, we are looking for galactorrhea, amenorrhea, infertility, and osteoporosis. So two different things, two different genders. Okay. What are the regulations of prolactin? Prolactin secretion from the anterior pituitary is tonically inhibited by dopamine. Okay. What does tonically inhibited mean? Meaning continuously. Continuously is inhibited by dopamine. From where? From tuberoinfundibular pathway of the hypothalamus. Prolactin in turn inhibits its own secretion by increasing dopamine synthesis and secretion from hypothalamus, which we will see here. TRH increases release of prolactin secretion, example, primary, secondary hypothyroidism. Again, we did talk about how TRH leads to release of TSH, which is a thyroid hormone stimulation, right? Thyroid stimulating hormone. But we also said TSH is also going to be closely associated with prolactin. So if you increase TSH somehow, you're going to increase the release of prolactin. If you decrease TSH, you're going to decrease prolactin. So here's the same thing. TRH, which is essentially going to stimulate your TSH, will also stimulate the release of prolactin, known as prolactin secretion. And why would you have TRH being there? In hypothyroidism, increase in TRH, primary or secondary, doesn't matter, but you have hypothyroidism that's going to cause increase in TRH. dopamine has a stronger, but the problem now here is dopamine has a stronger effect on prolactin regulation than TRH does. So dopamine is like a proper holding down prolactin release, which we'll see in this picture. Let's look at the picture first. Okay, look, so we have a hypothalamus. Hypothalamus, we have a dopamine. Dopamine is always, let's say dopamine is there. And dopamine is always, whenever it's there, it's going to inhibit the release of prolactin from anterior pituitary because it's there. So it's always, as we said, it's tonically, all the time, it's tonically inhibited by dopamine. Simple. Where is dopamine coming from? It's coming from tuberoinfundibular pathway. And if you want to know that, go back to CNS. There's a proper nice picture of tuberoinfundibular pathway of hypothalamus. Okay, that releases dopamine here. And so one thing we learned, dopamine is there and that inhibits this prolactin secretion. Well, the TRH, again, coming from hypothalamus, if it's there, it's going to stimulate. But we learned that dopamine has a more effect than TRH. So even if you have a TRH, but if you have dopamine there, it still is going to be inhibited unless you have more and a lot of TRH there. So let's talk about how, first of all, TRH is stimulating prolactin. So let's take a look at this. So in hypothyroidism, what's going to happen is you have increase in hypothyroidism. Again, you have a low T3, T4. Low T3, T4. The body's like, hey, we need to make some thyroid hormones. Okay, so we need to secrete TSH. But in order to stimulate TSH, you need TRH coming from hypothalamus. So you have an increase in TRH that stimulates TSH, and that leads to stimulation of T3 and T4. So let's go back a point here. Hypothalamus causing release of TRH. That TRH is going to stimulate, again, TSH, and that is going to cause, first of all, TSH is coming from anterior pituitary, as the TRH is coming from hypothalamus. And then it's going to go on to the thyroid itself and stimulate the thyroid T3 and T4 secretion. And other than that, this is normal physiology of TRH. But now the thing with this TRH, let me change color, is that TRH is going to stimulate not only the TSH in the anterior pituitary, but also it's going to stimulate receptors of the electrotrophs, which leads to prolactin, increase in prolactin. Okay, so that is there. But again, coming back to this point, that dopamine has a stronger effect on prolactin regulation than the TRH does. So TRH does not have a strong regulation on it. So dopamine is the main guy. Okay, so now looking at this picture, some other things that we have is when the baby is hungry, the baby cries. When the baby cries, the higher cortical center is going to inhibit hypothalamus, which inhibits the dopamine releasing. When you inhibit dopamine, there is increase in prolactin. That increase in prolactin causes milk production. Okay, but there are so many other things that are going to be associated with prolactin. So let's talk about those. Medications. Whatever is going to inhibit dopamine will lead to increase in prolactin. Medication. Let's talk about some medications here. Dopamine antagonists. Most antipsychotics are dopamine antagonists, like metoclopramide. For example, metoclopramide and estrogens. Example, OCPs have estrogen. Pregnancy also have estrogen. They all lead to prolactin secretion. So medications, chest wall injury. Via ANS will also inhibit the release of dopamine, causing increase in prolactin. Nipple stimulation. Again, what is this? It's called breastfeeding. Breastfeeding, nipple stimulation, suckling response of a child will also inhibit the release of dopamine. Okay. So for the medication, just remember we talked about antipsychotics and antidepressants also. So antipsychotics and antidepressants, they both have anti-dopamine. So whatever medication you think of, which are these two, antipsychotic and depressants, which are dopamine antagonists, will cause increase in prolactin. Okay. Um, what else we can think of? Again, we are trying to see who's increasing prolactin, right? Just keep that in head. Who's increasing prolactin? Medications, we talked about. These three things we did talk about. Other things are verapamil. Verapamil is a um, selective cardiovascular calcium channel blocker. So it's only one. It's a calcium channel blocker. Let's just put it here first. It's a calcium channel blocker, verapamil, that will also increase in prolactin. And this metoclopramide, which is antiemetic, also would increase the prolactin. What else would increase prolactin? We talked about primary, secondary hypothyroid. That would eventually lead to increase in TRH, and that would stimulate the release of prolactin. OCPs, pregnancy, which is basically estrogen, which also leads to release of increase in prolactin. So again, estrogen, main thing here, increases prolactin release. Now, one thing which isn't mentioned here is the GN. They said up top that the growth hormone with GH is structurally homologous, right? So GH co-secretes PRL, which is prolactin. Okay. Now, one thing which is abnormality, which is renal failure. When you have a renal failure, so again, prolactin gets eliminated by the renal failure. So when you have a renal failure, you have more and more prolactin. So you have more prolactin when you have renal failure. Okay. So now we did talk about how we have increase in prolactin. Now here, if you have increase in prolactin, it's going to cause two things. It's going to inhibit GnRH. Now, this is the normal function of GnRH. What was GnRH doing? Stimulating FSH, stimulating LH, causing ovulation, causing spermatogenesis, right? And when you knock this out, because now you're inhibiting GnRH, you are going to have the things we talked about, for example, amenorrhea, infertility, decreased libido, and decrease in estrogen. Okay. Now, we all know this now. But now the next thing is it also stimulates. So it inhibits one thing, it stimulates one thing. The other thing it stimulates is going to be milk production. Now, there's going to be an important point here that the milk production, let's talk about it actually. So milk production, so this prolactin is going to stimulate lactation in pregnancy, right? Or lactogenesis, or milk production in pregnancy, right? Now let's talk about what's happening in pregnancy. That's very high yield actually, and very simple. So in pregnancy, what's going on here is in pregnancy you have placenta. Now that placenta releases progesterone. That progesterone, pregnancy, again, placental progesterone inhibits the lactation. So let me just do this here. Inhibits lactation. So the milk doesn't let down in pregnancy. So milk does not let down in pregnancy. in pregnancy. Okay. So this guy, so okay, look at it. Prolactin, change color here. Prolactin is stimulating milk production. Milk production. Okay, a lot of milk has been produced, but now we need some physiological factor which would not let it let down. Meaning it will not let it uh, milk. There will be no milk let down while it is greatly being produced. How do we do that? Well, nature, you have a normal homeostasis, you have pregnancy, you have placenta, which releases progesterone. High yield that progesterone inhibits the milk letdown. So guess what? When you don't have placenta, when the baby gets delivered, you don't have, the placenta also gets delivered, you don't have any more placental progesterone, and you have suckling, and that causes oxytocin. So the milk is already will come down. So after pregnancy, let me write it here. So after pregnancy, what's going to happen is you have decrease, or you will not have anything here, because when you don't have placenta, you will not have progesterone. So when you have a decrease in the progesterone after pregnancy, that is going to cause, that is going to not inhibit that letdown of the milk. So after pregnancy, oxytocin can easily cause the milk letdown. Okay, that's all for this one. But now important point was only one thing, that was a placental progesterone inhibiting the lactation while in pregnancy. And that was the important point. Other than that, you have what else you might have? Okay, some other things, let me just talk about them here as well. That is that it causes gynecomastia, right? Gynecomastia in males. So what's really happening is that you have, when you increase the estrogen. So let's take a step back. I should tell you the whole story here. So increase in estrogen to testosterone ratio will lead to gynecomastia. Okay. If you have a normal, let's say if you have a normal testosterone, that should inhibit the gynecomastia. So again, what is the pathophysiology of gynecomastia? When you have increase in estrogen in males, then the testosterone ratio, that's going to cause gynecomastia. Okay. And that's pretty much it. Let's quickly review this so we can move on to the next part. Okay. Prolactin. Well, prolactin, it is from anterior pituitary, two things. One, milk production. Second, decreases in GnRH, which causes ovulation and inhibits the ovulation in females and inhibits spermatogenesis in males. But when you have an excess amount of prolactin, which is seen in, when would you have excess amount? The most common pituitary adenoma is prolactinoma. That's also high yield. Most common pituitary adenoma is your prolactinoma. Prolactinoma is going to secrete a lot of prolactin, and these patients are going to present with so let me just put it here. So you are going to present with, in females, you have galactorrhea, amenorrhea, infertility, osteoporosis. But in males, you're looking at gynecomastia, infertility, decreased libido, and impotence. But on top of that, also you will see you will see loss of peripheral vision, uh, and a mass effect. So because you have prolactinoma, which is a mass, so you will have a mass effect. Mass effects are going to cause headache and this loss of peripheral vision, which is the bitemporal heminopsia. Because that mass, when it compresses the optic chiasm, let me draw optic chiasm quickly so you know what I'm talking about. So you have an optic chiasm here. This is the optic chiasm, roughly. So when you are going to have a mass which is going to sit on this optic chiasm, is going to compress that. When you compress the optic chiasm, you are going to get bitemporal hymenopsia, which is you will not be able to see the temporal sides. So the sides will not be seen. So bitemporal, again, temporal meaning periphery. So loss of peripheral vision will be there. And on top of that, you will also have signs and symptoms of increased prolactin, which are all right here. Okay. As for regulation, we have prolactin secretion from anterior pituitary, tonically inhibited by dopamine. Prolactin in turn inhibits its own secretion, which is a negative feedback, by increasing the synthesis of dopamine and secretion from the hypothalamus. TRH would also increase prolactin secretion, but dopamine has a higher, stronger effect on the prolactin. Now, important point is going to be something called as damage to the pituitary stalk. So let's talk about that as well. A clinical tie-in that if you were to damage the stalk, which is known as pituitary stalk, right? Pituitary stalk. This right here. This can lead to, if you have damage here, now what's going to happen is it will lead to inhibition of all anterior pituitary hormones except for prolactin. Except prolactin. Why? Because remember that from this pituitary stalk, dopamine was coming and inhibiting the release of prolactin. So when you lose the stalk, now the dopamine can't come down, so there's going to be increase in prolactin. So there's going to be increase in PRL, prolactin. That's one thing. And the second thing is going to be one more thing here. Clinical tie-in is during pregnancy, you have increase in prolactin. Throughout the pregnancy due to estrogen stimulating. So you have increase in pregnancy that causes increase in estrogen, which is mentioned here in the book. So you have pregnancy that causes, you have increase in estrogen during pregnancy that stimulates the prolactin release, but doesn't cause lactation. Again, it's going to cause milk production, but there is no lactation because lactation is inhibited by PP, which is placental progesterone. Again, look at how amazing this is physiologically. Estrogen doing one thing, beneficial. Progesterone doing again same thing, beneficial, but total opposite way. Amazing. Okay, and finally, when you don't have placental progesterone, you will not be inhibiting the lactation, and after the birth, you can have the lactation. Okay, and that's going to be all. One last thing, actually, for the treatment of prolactinoma. What is the treatment for prolactinoma, which is the most common pituitary adenoma? Well, the treatment is going to be either you can give a dopamine agonist, which is cabergoline, or because it's a prolactinoma, it might not function, right? So you have to do something called as transsphenoidal surgery. And that is going to be all for prolactin. Moving on with the thyroid hormone. So thyroid hormone, it produces T3 and T4. T3 is tri-iodothyronine and thyroxine. thyroxine. These are all iodine-containing hormones that control body metabolism rate. Body metabolism, right? What is the source of these hormones? Well, they are coming from the follicles of the thyroid. Okay, let's see the follicles here. Okay, no follicle, but here, if I just roughly draw it, there are follicles through which these hormones are produced, and I think we will see that in the pathology section. But follicles of thyroid. So you have an hormone which is known as 5'-deiodinase, which converts T4, the major thyroid product, to T3. Let's take a look at that. So you have, here's the T4, and here's the T3. So 5'-deiodinase in the periphery converts the T4 into T3 T4. Okay, and also gives rise to reverse T3, which is known as RT3. Now RT3, let's mention about this guy. RT3 is inactive metabolite. It is just an inactive metabolite of T4. Okay, inactive metabolite of T4. Okay, so this is one hormone. Moving on with the next thing, what do we have? So the mnemonic that they have, 5, 4, and 3. 5 is all the way in the periphery. Then let's talk about the 4. 5 converts into the 4 and 3. This is pretty easy. I don't know why they have mnemonic, but 5, 4, 3. Okay, that makes sense. Peripheral conversion is inhibited by, now important thing is this, you could inhibit that conversion by glucocorticoids, beta blocker, and PTU, which is propylthiouracil. Okay, let's look at that now. So this enzyme can be inhibited by glucocorticoids, propyl PTU, glucocorticoids, and beta blockers. Okay, keep that in head, and we will read the next one now. Now, reverse T3 is a metabolically inactive byproduct of peripheral conversion of T4, and its production is increased by growth hormone and glucocorticoids. Okay, great. Functionally, we did talk about this one. So functions of thyroid peroxidase include a couple things here. First, we have oxidation, organification of iodine, and coupling of MIT and DIT. So again, oxidation, organification, and coupling. It is inhibited by PTU, which is again propylthiouracil, and methimazole, which would also inhibit this. So DIT would lead to T4. When you add these two DITs, you will cause T4, leading to formation of T4. And what is DIT? Well, DIT is simple. It's a diiodotyrosine. Diiodotyrosine. Okay, and DIT plus MIT, what is that again? If it's D is di, the M is going to be the mono, right? Simple. So monoiodotyrosine. So when you add 2 and 1, that's going to be T3. Now, there's an important thing called Wolff-Chaikoff effect. Well, that is protective autoregulation. Why is it protective autoregulation? When you have a sudden exposure to excess iodine, which would temporarily turns off thyroid peroxidase. Now, the question arises that, okay, when you have, let's say you're saying, okay, let me just go back here, look in the picture. From blood, you have this iodine, iodine going into this thyroid follicular cells, right? From blood, it's just taking up all of this. So the question arises, when you have a lot of iodine, right? A lot of iodine, does it take everything? And I mean, if it takes everything in, then it's going to cause a lot of formation of T3, T4. So just because you have a lot of iodine in your, let's say, diet or something, or that's actually with the iodine being exposed in radiation. But here the question arises that, okay, if you have a lot of iodine, would everything be taken up? No, it's not, because of Wall-Chaikoff effect. So Wall-Chaikoff effect is a protective autoregulation, because when you have a sudden exposure to excess iodine, it temporarily turns off the enzyme thyroid peroxidase. When you turn this enzyme off, you have a decreased T3, T4 production. And here's the thyroid peroxidase. Okay, so iodine, let's look at this now. So iodine gets in. Again, this is getting in here is again stimulated by TSH. TSH stimulates the receptor here, which causes the iodine to be taken up by the thyroid follicular cell, epithelial cells. And this is called sodium iodine symporter. Sodium, because sodium is coming in. Iodine, because iodine also coming in. Symporter, because both are going in. Right? And that, when the iodine is here inside the thyroid follicular epithelial cell, now that iodine goes out into the lumen of the follicular cell, and when it goes out, it forms I2, which is the oxidation. So you have oxidation here, organification and coupling. So with the oxidation, now you have formation of I2, which is known as now iodine. Iodine. Here, I minus here, I negative, is the iodide. And formation of iodine occur when there's an oxidation. Okay, and the whole thing is just, there is one enzyme responsible for all of this oxidation, organification, coupling. Whole thing is done by one enzyme known as thyroid peroxidase. TPO, thyroid peroxidase. Okay, so TPO is there. Now there is another thing that is the tyrosine. You can see it right there, TG, tyrosine. This tyrosine, my bad, this is thyroglobulin, which, my bad, one second. This TG is thyroglobulin, okay, which has tyrosine residues attached to it. And you can see it by in this picture. Let me erase this. So this is thyroglobulin, and these guys have tyrosine attached to it. And why am I mentioning that? Just so that if you think about it, if they say anything with the thyroglobulin and tyrosine, you will just think about thyroid development of the thyroid hormones. Tyrosine, thyroglobulin are all there associated with the thyroid hormone production. Okay, so you have tyrosine. With the tyrosine, when the tyrosine adds to I2, which is the iodide, so it leads to MIT formation, which is the monoiodotyrosine, right? And with the D is the 2, so diiodotyrosine. Simple. Again, let me just write this simple thing to make it easy. So when the tyrosine plus I2 equals MIT, tyrosine plus iodine plus iodine leads to formation of DIT, which is diiodotyrosine. Simple, but not that important. Just know a little bit of that, and tyrosine and thyroglobulin, you should be good to go. Okay, so here now we're at this point, we talked about how the oxidation caused I2. Now what's going to happen is that you have organification and coupling. So organification is that to this thyroglobulin, what's going to happen is you have addition of that. Now we form the MIT and DIT, that's called organification. MIT, DITs are now attached with those tyrosine molecules, right? Call it MIT, DIT. And then what's going to happen is called coupling. Now these guys will join together and they will form either T3, T4, and that's called coupling. So with the coupling, now you have, look, you have T3 green is T4. Okay, and that then goes back. Endocytosis occurs. Now, if you look here, the entrance of the iodide was also stimulated by TSH. As same thing here, the endocytosis is also stimulated by TSH. So TSH has a major role in production of your thyroid hormones, right? And that's with this TSH being here stimulates the endocytosis of these hormones. And with that, you have proteases which will cleave down these hormones, T3, T4, send them in the blood, and will also put this back into this in these follicular cells, so it can be it can go back into the follicular lumen, and there's a cycle full on that would just rotate again and again, and the product that we are getting out of it is T3, T4. Okay, with the T3, T4, we did talk about how you have, now important question is that you have a lot of production of T4, okay, and lesser amount of T3, because when they go, eventually when the T4 goes into the effector organ, there's an enzyme known as 5' deiodinase, which will convert that T4 into more active metabolite, which is T3, and also reverse T3, which is inactive metabolite. So that T3 would lead to major function of the thyroid, major thyroid functions. Okay. So let's now, with that, let's read, and then we will understand it better. Give me 1 second. Sorry about that. Just 1 second. Okay, now let's just read the sources here. All right. So again, we talked about how the T3 till this point. Let's move on with this. Reverse T3 is metabolically inactive, right? And its production is increased by growth hormone, glucocorticoids. Again, whatever is going to inhibit this will increase inactive metabolite of it. Simple. The second thing was about thyroid peroxidase. 3 things are done: oxidation, organification, and coupling. Coupling is simple. You know, coupling is adding together. Organification is just think about when you're adding that iodine with the tyrosine molecule. Oxidation is when you are trying to have that iodide, converting that into oxidize it and make it iodine. Iodide to iodine, but not important. Remember 3 things: oxidation, organification, coupling. That's important, nothing else. Inhibited by the whole thing. The important thing is this thing. TPO is inhibited by PTU and methimazole. DIT, T4, DIT, MIT, T3, high yield Wolff-Chaikoff effect, which is protective, which would temporarily inhibit this TPO, which lead to a decrease in T3, T4. Let's talk about the functions. Now, the functions are that it's only free hormone is active, high yield, only free hormone is active, meaning whatever is bound to, it's not going to be active. So whatever is free is going to be active. T3 binds a nuclear receptor, again, high yield. Nuclear receptor. So there are only a few things which bind directly going to the nucleus and have their receptor over there. So that's one of the, that's just T3 is one of them. Binds directly to the nuclear receptor with great affinity. Then the T4 and T3 functions are going to be 7B's, important: brain maturation, bone growth, which is synergism with the growth hormone and IGF-1. So bone growth is not only dependent on GH and IGF-1, but also your T3. Then you also have beta adrenergic effect. Beta adrenergic effect is because this increases beta 1 receptors in the heart. So when you have increase in beta receptors of the heart, more and more stimulation would cause, for example, if you have increase in catecholamines. So basically, let me write this down. So when you increase the beta 1 receptors on the heart, essentially you're causing increase in sensitivity of catecholamines, right? Because when you have the catecholamines come down, you have a lot of beta 1 receptors. When they get stimulated, it's going to cause increase in cardiac output, increase in heart rate, increase in stroke volume, increase in contractility. So if you were to block it by beta blocker, so you're alleviating all these adrenergic symptoms in thyrotoxicosis. Again, in thyrotoxicosis, you have a lot of TSH, T3, T4. That's going to cause more and more beta 1 receptor, causing all these problems. So you could just give beta blocker, block this receptor, and alleviate all these adrenergic symptoms. Okay. Basal metabolic rate, high yield. Basal metabolic rate is increased by the T3. How? Because it increases the sodium potassium ATPase pump. When you increase sodium potassium ATPase, for example, you had, let's say, 5, now you're increasing to 10. The more you have, the more O2 is consumed. The more O2 is consumed, meaning more O2 is needed. When the more O2 is needed, your mitochondria is just going to take up all those ATP and make causing those ATP to run this channel. And ATP, again, you're breaking down all that glucose that you have, everything. So increasing basal metabolic rate, you're not running, you're not doing anything. It's a basal metabolic rate. Increase in ATP production because sodium potassium is ATPase channels. It is an ATPase channel, needs ATP, causing increase in O2 consumption, increase in respiratory rate, increase in body temperature. Okay, blood sugars, increase in blood sugars by increasing glycogenolysis, breakdown of glycogen, and gluconeogenesis, formation of more glucose. Break down lipids. When you break down lipids, there's lipolysis. Again, more lipids, more breakdown of fats. Stimulates surfactant synthesis in babies, important. It also stimulates the surfactant. So one thing important point is, see, it's increasing almost everything. But here, when you're increasing lipolysis, which is the breakdown of lipids, when you're breaking down lipids, you would have decrease in concentration of cholesterol and triglycerides. Decreased concentration of cholesterol plus triglycerides. And that is done through increasing, first of all, increasing LDL receptors in the liver. When you have increased LDL receptors in the liver, let's say this is the LDL receptor, more and more LDL from blood is going to taken up by the liver. So low LDL is going to be in the blood, which is a good thing, right? And increase in cholesterol secretion in bile. So when the cholesterol goes into the bile, again, you're decreasing the total cholesterol. Okay. What else would be there? Surfactant, for sure, very high yield. In babies, that it increases surfactant, very high yield. Okay, let's talk about the basal metabolic rate again one more time. So basal metabolic rate increase by increase in sodium potassium ATPase, right? So what the T3 does is increases the synthesis of all these pumps, meaning increases the more and more pumps, right? So when you increase these pumps, more and more ATP is consumed because it's an ATPase channel. It's going to require ATP, and when you increase when you consume more ATPs, you need more oxygen. Consumption is going to be there, and the body temperature is going to go high. And respiratory rate would also go high because you have more, you have consumed more. So to provide enough O2, you have to go into increase in respiratory rate. That is going to be there. And I guess that's pretty much what we have. One more thing here for the brain maturation. It is in the perinatal period. So perinatal period. Brain, we will see how in pathology that how in the perinatal period, if we don't have any thyroid hormone, how in the perinatal period we will not have a brain maturation. So perinatal period requires T3 because mother's thyroid hormone T4 does the job during pregnancy. Why? Because you have mother T4, which would during pregnancy, which would not show any deficiency, but after that, it's going to be a problem if there is a problem, right? Okay, and that's going to be all here. Now, going on to the regulation part. Well, the regulation is TRH. Excuse me. TRH stimulates the TSH release, simple, that causes stimulation of follicular cells. These are the thyroid follicular cells. Thyroid stimulating immunoglobulin TSI may stimulate the follicular cells in Graves' disease, high yield. So TSI does the job of TSH in Graves' disease. Again, what was the job of TSH? Stimulate follicular cells. What's the job of TSI? Stimulate follicular cells. So in Graves' disease, you have TSI, which is immunoglobulin, which would also stimulate the follicular cells. We will talk about that in details later on, but just brushing up some superficial knowledge here. So negative feedback is primarily by free, again, because what we said, the free is the active. So when we have the active hormone, that is going to give a negative feedback. Either T3 or T4, both can do that. Anterior pituitary decrease sensitivity to TRH. Hypothalamus decreases TRH secretion. Again, let's take a look at this picture to see the negative feedback. So we have hypothalamus. Hypothalamus releases TRH, which goes on the anterior pituitary, stimulates the release of TSH. That TSH goes and stimulates the thyroid follicular cells, leading to release of T3, T4 to the effector organ. Now, T3, T4 are going to inhibit anterior pituitary as well as hypothalamus. With the anterior pituitary, what they're doing is they're like, hey, you don't need to be sensitive to this guy. We are already trying to stop this guy, but if it still is coming, we want you to be non-sensitive. Don't be sensitive to it, meaning do not get stimulated when the TRH is there. That's what is written there. Decrease sensitivity to TRH. In the hypothalamus, they're just saying, hey, man, decrease the TRH release, please. Simple. Okay. Other than that, you have this thyroxine binding globulin, TBG. Thyroxine binding globulin. This is the one which binds to most of the T3, T4 in blood. Thyroxine binding globulin, important. It is bound is inactive again, and what is free is going to be active, simple. But when you increase, the important thing is when you increase the TBG, which is thyroxine binding globulin in pregnancy, OCPs, for example, estrogen would cause increase in TBG, would lead to increase in total T3, T4, right? So in anywhere you are increasing the thyroxine binding globulin, that is going to increase T3, T4, but only bound. And we said bounds are inactive, but they're still there, right? The second thing is if you decrease the TBG, which in case you're decreasing steroid use, nephrotic syndrome, in nephrotic, you're losing it, it's going in urine, Okay, so this guy would cause decrease in total T3, T4, but again, they're all inactive. Now, important point is T3, T4 are only lipophilic hormones with charged amino acids and require specific transporters to diffuse into the cell, facilitated diffusion. Again, simple but high yield, that they are lipophilic, charged, and they require something. They require specific transporters to when they want to go into the cell. They can't just go like steroids. I guess they also have a receptor. But here, what we're talking about is they can't just diffuse in. They need the facilitated diffusion, require specific transporter. Okay, and that's pretty much all. Let's go through this. Okay, we're talking about thyroid hormone. Simple. Thyroid hormone is the T3 with the triiodothyronine and thyroxine T4. They're all iodine-containing hormone that control the body's metabolic rate, and the body's metabolic rate is controlled by increasing the synthesis of sodium, potassium, ATPase, which leads to increase in O2 consumption. Respiratory rate is increased, and body temperature is also increased. The source of this is simple: from the follicles of thyroid. You have this 5' deiodinase, which converts T4 to T3, mnemonic 543. Peripheral conversion could be inhibited by glucocorticoid beta blocker PTU, but not methimazole. Reverse T3 is just inactive metabolite of T4, and it could also be increased by growth hormone, glucocorticoid. Now, there is another hormone known as thyroid peroxidase. The major hormone for synthesis does three things: oxidation, organification, coupling. It is inhibited by two drugs, PTU and methimazole. Important thing, Wolff-Chaikoff effect. It is a protective mechanism. It turns on when you have sudden excess of the iodine, and it temporarily turns off the same hormone, which is the thyroid peroxidase, leading to a decrease in T3, T4. 7 Fs are going to be brain, bone, beta-adrenergic, basal metabolic rate, blood sugar, blood lipids, and surfactant in babies. Regulation is super easy. TR8 stimulates TSH, which stimulates the follicular cells, leading to release of T3 and T4. Negative feedback by T3, T4 inhibit both hypothalamus and pituitary. Important thing is thyroxine binding globulin, which is increased in pregnancy and OCP use because estrogens are going to the high yield. Estrogen causes increase in TBG, which leads to increase in total T3, T4. Steroid would decrease it, and nephrotic syndrome would also decrease it. T3, T4, they require a transporter to go into the cell. Okay. What else we can have? One more thing, important point is going to be your radioactive iodine. Radioactive iodine. It is in small. For example, if you were to give it in small dosage, which was actually used for imaging purposes, right? But the large, if you give in the large doses, it destroys the gland. And it is when it destroys the gland. So guess what? It's used in hyperthyroidism. Now, these large doses can also be released if there's a nuclear accident that is going to cause, first of all, it's going to cause radiation-induced hypothyroidism. One thing. Second thing is going to be a thyroid carcinoma. So when you have a thyroid carcinoma in people who are exposed to some nuclear accidents, just think about thyroid carcinoma. again in young patients. Okay, that's one thing. Other things are going to be something known as potassium iodide. Potassium iodide, Ki. This competitively inhibits the thyroid uptake of iodide. So competitively inhibits the thyroid uptake of iodine, or radioactive iodine, any iodine. So the treatment of nuclear accident is you give patients potassium iodide. So when you give potassium iodide, it's going to inhibit the take up of that radioactive radioactive iodine, so it does not cause the destruction of the thyroid gland. Okay, that's also important. Let me take a look at some extra points which are sort of an ideal. Okay, amiodarone, let's talk about that. Let me erase this part. So after this, we're gonna have 5 minutes or 10 minutes break, and then we'll continue with that. But let me talk about amiodarone. Okay, some important drug here when where you see Walsh-Chaikoff effect is for example, amiodarone. Let's just write it here. Okay, amiodarone. So amiodarone, it contains iodine, right? When it contains iodine, it can lead to, with the Walsh-Chaikoff effect, it can lead to hypothyroidism. It can lead to hypothyroidism. But this amiodarone also, with Walsh-Chaikoff, it inhibits, it leads to hypothyroidism, but also it inhibits the 5' deiodinase, which leads to decrease in T3 and T4, which leads to actually T3, right? Because T4 converts into T3 by this enzyme. So when you inhibit this enzyme, you cannot have T3. So when you don't have T3, you are going to cause increase in TSH. Okay, that's important thing for the amiodarone. Let me see one more point for this estrogen pregnancy. Less I just want to mention this beta subunits. Let me make sure that it is, yeah, beta CG, yeah, that's important. So let's just mention that point. Last point here. Okay, one last point here is going to be that we did talk about how the beta HCG has the same subunit as TSH, right? So when you have increase in beta HCG, it's going to stimulate again the thyroid. That is going to release again increase in free T4 and eventually causing decrease in TSH. Remember that beta HCG has a connection here. Okay, so yeah, that's pretty much it for thyroid. And let's take a break. If you have any suggestion for the break, how long should we have the break for? Maybe 5 minutes, 10 minutes, 15 minutes. Let me know in the comment, please. And we will have that break. And we will get back and finish the rest. We are going to tackle all of the physiology today. Because somebody asked, what is physiological histological component of gynecomastia? Are you talking about like that terminal duct, the terminal duct, lobular duct, or I don't know if what was the question, but 5 minutes break. Okay, great. So I'm just gonna put on the timer. We can have a break, and then see you guys back after the break, after 5 minutes. And if you have any question, you can always write down, and I'll answer that. Yes, they will be here. Okay, welcome back, guys. Let's get started. A little bit delay here, but okay, let's get started quickly. Okay, hopefully you can hear me. If there's any sound problem, anything, you can let me know. ASAP. Number from my end, everything is good. Okay. All right, let's talk about the next thing we have is the parathyroid hormone. Parathyroid. Where the parathyroid is the source is the chief cells of the parathyroid. The function is going to be you're increasing free calcium in the blood, which is the primary function, right? Increasing calcium and phosphate absorption in the GI, increasing calcium phosphate from bone resorption, increased calcium reabsorption from DCT, decrease in potassium, not potassium, phosphate reabsorption in the PCT. I'm reading right now, but I'll make things very simple in a bit. Also increases 125 OH2 D3, which is the active form of vitamin D, which is calcitriol production by activating enzyme known as 1-alpha hydroxylase. In the PCT, the mnemonic is try to make D3 in the PCT. Okay, so these are all the functions of PTH. Again, we said the PTH, his job is to increase calcium and dump phosphate. So let's just write it here. Increase calcium, dump phosphate. With a P, you can just say PTH is a phosphate dumping hormone. Phosphate, P for phosphate, is a phosphate dumping hormone. Okay. That's the whole function here for the PTH. Now, important point, let's talk about one important high yield point that you have third and fourth pharyngeal pouch, third, fourth pharyngeal pouch, which leads to formation of the parathyroid glands. Okay, and the parathyroid gland lead to release of the parathyroid hormone, right? Now, if you have an absence of these pharyngeal pouch, for example, in DiGeorge syndrome, you have absence of these third and fourth pharyngeal pouch, so you will not be making PTH. You will not have parathyroid gland. Okay, and one step, this is all about your embryology associated tie-in. Now, one more important thing is that there are two hormones. Let's just write it here. There are two hormones which are closely regulating calcium and phosphate. First thing, as we're talking about, is the PTH. Okay, and the second thing we have is vitamin D. Vitamin D, active vitamin D, which is 125 OH2 D3. These guys are the primary two hormones which regulate the calcium and phosphate homeostasis. So in which PTH is just doing minute to minute homeostasis concentration, meaning it regulates change variability minute to minute. While this vitamin D, it regulates levels in the longer term, over the longer term. So longer term, you're looking at release of vitamin D, but in a minute to minute regulation, you're looking at PTH being the main guy. Okay. So now what is the net effect? Increases the serum calcium because it's a phosphate. PTH is a dumping phosphate dumping hormone, P for PTH. P for phosphate dumping hormone. So it's going to decrease the overall phosphate, increases urinary phosphate, increases high yield, increases urine cyclic AMP. Okay, so that's there. And one important point for the bone is that it does not directly cause the increase of calcium and does not directly stimulate the release of calcium, but how the way it does it, that it increases. So let's just write it here. So in the bone, you have two cells. You have osteoblasts and osteoclasts. Now the PTH, let's change color. PTH is going to stimulate these osteoblasts, which are the bone forming cells. It's going to stimulate these osteoblasts. When these get activated, they secrete the MCSF, colony stimulating factors, that then release to stimulation of, in turn, they release the stimulating factors which stimulate osteoclasts. Now, osteoclasts, that's only one of the pathways. Second pathways, they have to have the expression. So osteoblasts have something known as rank L, meaning rank ligand. Let me write it down, rank L, which is the rank ligand. And the osteoclasts have the receptor for it. So they have the rank, which is the receptor for rank ligand. So the second thing is going to be that you have PTH is causing the expression of this rank L, which then binds to this rank receptor and activates this osteoclast. And when the osteoclast gets activated, now you will have bone resorption, right? And with the bone resorption, you're going to get increase in calcium and phosphate also. So phosphate and calcium are in the bone. When you resorb the bone, the phosphate and calcium will go from the bone outside in the serum. So you will cause increase in calcium and phosphate. Increase in phosphate levels in serum. Okay, this is very important that the PTH, again, I'm just going to go through this quickly. PTH does not directly stimulate the osteoclast. It indirectly causes increase in calcium and phosphate from the bone by causing stimulation of osteoblast, which lead to release of MCSF, which stimulates the osteoclast. But on top of that, you need a second signal. That's the rank ligand binds to the rank, activates the osteoclast. Then there is a bone resorption, which causes increase in calcium and phosphate. But here you see you have calcium and phosphate, both are increased, right? So you want to dump this out in the kidneys. So that's exactly what PTH is going to cause. So it's going to decrease phosphate reabsorption. When it goes into the kidney, it does not even reabsorb the phosphate. So all that phosphate dumps into the urine, okay? And that is denoted right here. You have increase in urine phosphate, simple, right? So that is with that. What else? Let's just take a look. We talked about bone. We talked about kidneys. So let's just write here. So in bone, we are causing increase in calcium, increase in PO4-3, which is phosphate. But in the bone, well, in the blood and in the GI system, it's just again trying to absorb calcium and phosphate. Bone also doing the same, but only in the kidneys it's only causing increase in calcium and dumping phosphate. Then vitamin D, active vitamin D, which is calcitriol. This calcitriol production is increased by PTH, stimulating 1-alpha-hydroxylase. And when the 1-alpha-hydroxylase gets stimulated, it converts. Let's just take a look at this picture so it makes sense. So if you look here, you have 1-alpha-hydroxylase, you have inactive vitamin D to active vitamin D. This 1-alpha-hydroxylase, it's stimulated by PTH. So it converts inactive vitamin D to active vitamin D. Okay, and There are some other factors which would inhibit this, again, same enzyme 1-alpha hydroxylase. And where are we looking at? For example, we are saying this 1-alpha hydroxylase is also in it. First, let's talk about what else inhibits this. So it is inhibited by calcium itself. Calcium inhibits 1-alpha hydroxylase. There's another thing called as FGF23, which is fibroblast growth factor 23. High yield fibroblast growth factor 23. This also inhibits the 1-alpha hydroxylase. Now, where do we get this from? So fibroblast growth factor 23, it is released by osteocytes. In response to when you have increase in active vitamin D, these active vitamin D work on these. In response to active vitamin D, the osteocytes release FGF, which inhibits the release of more active vitamin D. So it's a negative feedback. Okay, but important. FGF 23. Fibroblast, and the full name is fibroblast growth factor 23. Okay. Now, one more high yield point is there are some other things where we get the 1-alpha hydroxylase, that is in the granulomas, in any granulomatous disease. So we have, let's just talk about it here. We have activated macrophages, right? Those activated macrophages, for example, in granulomatous disease, for example, sarcoidosis, for example, tuberculosis, for example, is non-Hodgkin lymphoma, or Hodgkin lymphoma, or any granuloma formation of diseases. You have these granulomas, these activated macrophages, they have 1-alpha hydroxylase activity. So when they have 1-alpha hydroxylase activity, they are going to cause increase in active vitamin D, right? And that increase in vitamin D will give you, as a result, increase in calcium levels. So with the granulomatous diseases, often you also increase in calcium levels. Okay, that is going to be there. So looking at this vitamin D, since we are talking about vitamin D here, so active vitamin D is going to work on the bone, causes increase in bone resorption. Okay, and that resorption is going to give us increase in calcium and increase in phosphate from the bone. Okay. With this, one more thing you will think of is with active vitamin D, you will have increase in mineralization of bone, an increase in remodeling of the bone. Okay, two things there. With the intestines, there is an increase in absorption of calcium and phosphate. Overall, in serum, if you look at the difference with vitamin D is that you have both the calcium and the phosphate, both are increased. With the PTH, parathyroid hormone, that's going to overall increase in calcium, but not the phosphate, because PTH, as I said, phosphate dumping hormone. It's going to dump that phosphate. Okay, let's take a look at PTH now. You have ionized calcium, decreased ionized calcium, increase in phosphate, or decrease in D3. So either you have decreased ionized calcium, or you have a lot of phosphate, or you have decreased vitamin D3. They're all activators for PTH. They all regulate PTH. They stimulate PTH. PTH comes from 4 glands. There are 4 parathyroid glands. They all secrete PTH. They go into circulation, stimulates 1-alpha hydroxylase, activates vitamin D. Vitamin D doesn't work. PTH goes into the renal tubular cells. And again, from here, you're causing that increased vitamin D will just go and have a negative feedback. And you will have increased D3 synthesis with the, you will have reabsorption calcium, phosphate dumping. Urine will have low calcium but high phosphate. Overall, that's the effect. Let's talk about regulation, which is also important. Regulation of this PTH is, first of all, you have the low calcium, which causes increase in PTH. High phosphate causes PTH, high PTH. Again, look at this new thing now. Now, magnesium is also there. Low magnesium causes increase in PTH. Very low magnesium causes decrease in PTH. So low and very low. So mild, low, mild decrease in serum magnesium, increase in PTH. Severely low magnesium will just decrease PTH. Why? Because magnesium acts as calcium. So let me write it down. Magnesium acts as calcium, on the CSER. CSER, let's talk about, first of all, no, you might ask what CSER. CSER is the regulate the secretion. This is a receptor on the PTH which regulate parathyroid hormone in response to changing serum calcium levels. So CSER, it's a regulation of PTH, which is normally sensing the calcium levels, and in response to that, it either stimulates or inhibits the PTH release. So let's talk about what would stimulate this receptor and what would inhibit that receptor. So first thing is that if you have the binding of the calcium, let's say binding of calcium to the CSRs, that is going to cause inhibition of PTH, because the CSRs are like, hey man, we already have calcium, we don't need you, right? And they would inhibit the PTH release. But if they sense, hey, there's a low serum calcium, meaning not a lot of calcium, not calcium binds to CSRs, they sense that, hey, the calcium is not there since we are like empty, so they release PTH. Leads to release PTH. PTH is like, hey, now the big guy is here. It's going to cause more calcium within the bloodstream. So now magnesium, on the other hand, which we were talking about, now the magnesium, let me just go a little down here. Magnesium binds to the same CSRs like calcium. So when it is just little low, mild low, okay, what it does, it acts as same calcium because it acts on, again, the same receptor, CSRs. Okay, now, but when it is very low, meaning very severely low, it leads to dysfunction of these receptors. CSR there's a dysfunction of CSRs. And that is why when they're very low, they have no action on the PTH. That's why you have a low PTH with a very low serum magnesium. And I keep saying CSR. So what is CSR now, you might ask? CSR is your calcium sensing receptor. Simple. Calcium sensing receptors on parathyroid or a parathyroid gland. Okay, that is all we have. Let's take a look at some extra things here. Pathology. So PTH, we did talk about the first thing. Okay, increase in rank L, which is the receptor activator of NF-kappa B ligand, secreted by osteoblasts and osteocytes. Okay, again, you have increase in ligand, which is a receptor activator of NF-kappa B. It is secreted by osteoblasts and osteocytes. They bind the rank, which is a receptor on osteoclast, and they're precursors to stimulate the osteoclasts. An increase in calcium. This causes bone resorption. Intermittent PTH release can also stimulate bone formation. Now, this is high yield. we said the PTH, its job is to cause bone resorption so we can have more and more calcium in the blood, right? Trying to get that calcium from bone, right? Now, if you were to give intermittent PTH, it is doing the opposite. It is actually stimulating bone formation. It is stimulating the bone formation. That's also very high yield. Now, intermittent PTH, uh, it's the now there's a, for example, in let me just write it down. For example, there is an osteoporosis. Osteoporosis treatment could be one of the treatment could be that you want to give an intermittent PTH, which is your teriparatide. Let me write it down. Teriparatide. Now, this teriparatide, uh, it is an analog of the PTH, which again causes what leads to bone formation, and that hence we are giving in osteoporosis. PTH, as they have mentioned, is the phosphate trashing hormone. P for phosphate. Okay, and that's very good actually. P, T, and H, phosphate trashing hormone. All right. The next thing here is high yield is going to be PTHRP, which is PTH related peptide, and this, as the name says, is a related peptide. It functions like PTH, and it is common increase in malignancies, for example, squamous cell carcinoma of the lung, renal cell carcinoma, RCC. So when you have increase in the PTHRP, it's going to act like PTH. Guess what's going to happen? You will have osteoporosis. You can have increase in serum calcium, and increase in serum calcium with a person who has a squamous cell carcinoma of the lung or RCC. You'll think about, okay, there's a lot of PTHRP being released, and it is released from the malignancy itself. Okay. Now, something for the phosphate. When we have increase in free calcium, now, okay, we did talk about how we have increase in free calcium and low phosphate in the PTH versus different thing in the vitamin D, in which case we will have both of them increased. Okay. One point also I have to mention here. This is the intermittent PTH. For example, if you were to give a continuous PTH, continuous administration of PTH is going to cause, again, the same thing: bone resorption, increase it will increase the osteoporosis. So let me draw the bone here. So let's draw a bone here. They're pretty bad in drawing, but okay, let me just try one more time. Something like this, I guess. Well, this is actually bad. Let's do this. Easy. Okay. Now we have, for example, now we know this is cortex. And just below the cortex, which is the hard bone, just below the cortex, we have the trabecular, which is a spongy bone here. So trabecular bone. And with this, with this, what is it? Teriparatide, you're basically causing the trabecular bone to increase in osteoporosis. You're trying to rebuild this trabecular bone. Okay, that is important. With the continuous PTH administration, you have bone resorption, which occurs at the cortex. So when you give a continuous PTH administration or normal PTH, when it is there, it's taking the bone out from the cortex. Okay, I hope that makes sense, but that is there. Let me see if there is anything extra that I could. emphasize on. Okay, I have a GI thing occurs via calcitriol. We talked about it. Increased secretary. On bone PTH action by bone. Okay, we'll talk about that thing. Okay, PTH kidneys. I guess let's talk about the kidneys. It's really easy but important. Okay, doctor, I will talk about that third and fourth pharyngeal pouch. And also see some, histological, combinatorial, physiological gynecomastia. I'll take a look at that one. Okay, maybe are you talking about like lobular units? So normal physiological gynecomastia occur when you have hyperplasia of the lobular units. But again, I'll definitely take a look at that and get you back on that. So let me just go back and revise that part, which is third and fourth pharyngeal pouch. Very easy. Okay, third and fourth pharyngeal pouch, simple. Third or fourth, or you can sometimes say third, fourth. So just make sure you're talking about both. Third/fourth, meaning third or fourth or both. Pharyngeal pouch, they form the parathyroid gland. So if you recall, in the DiGeorge syndrome, you do not form the third, fourth pharyngeal pouch, right? There's an absence of third, fourth pharyngeal pouch. And that's why when one of the things that you're not going to have is parathyroid, the other things are there's no thymus, there are no T cells, and so forth. So third and fourth pharyngeal pouch, again, recalling that third and fourth pharyngeal pouch give rise to, they form the parathyroid gland, and the parathyroid gland release the parathyroid hormone. So now, when you knock this out in your DiGeorge syndrome, now you're not having the parathyroid hormone. Simple. That makes sense. Okay, let's talk about kidneys here. Okay, now important thing, let's talk about something here for the kidneys. That how that PTH is causing two things in the kidney. So in the kidney, we have, let's mention kidney here. We have the PCT, right? And the DCT. So what's happening in the kidney that you have parathyroid is going to cause, in the PCT, it's causing inhibition of a channel, inhibiting a channel. This is urine, and this is your blood, let's say. So it's going to, why did I put PT in the urine? Okay, it's coming from the blood. Okay, PTH is going to inhibit this channel, which is trying to reabsorb the phosphate. Okay, and the PCT. Now remember, we're talking about PCT phosphate inhibition, phosphate reabsorption inhibition. Okay, and also in the PCT, PTH is stimulating 1-alpha-hydroxylase. Two things in the PCT. Now the DCT, on the other hand, is causing. Let's mention here. It's causing what? It's causing reabsorption of calcium from urine into the blood. So why did I draw all of this? Because you have to know the PCT and the DCT. It's not that it goes to the kidney, does one thing only the PCT. It's also working at the DCT. In the PCT, trying to block this phosphate and also stimulating 1-alpha-hydroxylase. But in the DCT, it's causing the calcium reabsorption. And that is what we have within the kidneys. Let's erase this part now. Okay, now lastly, we have on bone. On bone, we have PTH action is by stimulating the bone formation cells, for example, the osteoblasts, which in turn then stimulate osteoclasts, high yield, leading to increase in bone resorption. That's on the bone. While on the PTH stimulates, it has no direct function on the GIT. So PTH stimulates active vitamin D, which then in turn acts on the GIT tract, causing absorption of your calcium and phosphate. Okay, and that is going to be all for that. Okay. Let's see if there is anything clinical relevance. Increase our, yeah, start with CKD. Okay, yeah, important. Okay, high yield point is going to be, now let's talk about some extra details, high yield points. Okay, now one extra thing that we have is that, for example, if you give someone vitamin D supplementation, right? What's going to happen is uh, vitamin D supplementation in a moderate dose is recommended. Because if you were to give some excess dosage, so excess vitamin D will cause what? Let's talk about that. So excess vitamin D will cause symptomatic hypercalcemia, which will lead to, we'll talk about what it's going to cause, but it's going to cause impaired depolarization of NMJ, neuromuscular junctions, leading to muscle weakness, constipation, confusion, impaired concentration of urine in distal tubules, leading to polyuria, polydipsia, and this we will talk about how symptomatic increased calcium will cause. But chronically, vitamin D intoxication will cause renal stone formation, one thing, and bone demineralization, which then leads to bone pains. And that will also come up. And where do we see chronic vitamin D intoxication? For example, if you have chronic granulomatous disease, that is going to increase 1-alpha-hydroxylase, that is going to activate vitamin D, and it will lead to intoxication of that. For example, in sarcoidosis, right? That's just one of the things, but other things like tuberculosis, anything could be there. But this is all access. What about if we have a low vitamin D? Let's just change color here. Low vitamin D. Where do I write that now? Let's erase this and write it here. If we have low vitamin D in children, it's going to cause rickets. And in adults, it's going to cause osteomalacia. Okay, and that is all. Now let's talk about CKD. CKD, chronic kidney disease. What's going to happen is there is going to be impaired conversion of inactive to active vitamin D, right? Inactive to active vitamin D is going to be impaired, right? With that being impaired, now you don't have active vitamin D, right? As a summary of this. So there is going to be increase in FGF 23 in early CKD. Now you got to remember this. In earlier CKD, you have increase in early. Let me write it down. Early CKD. Okay. Which will lead to inhibition of that 1-alpha-hydroxylase in early CKD. But that's first thing. Second thing you will have is decrease in GFR, GFR is, because it's a CKD, for sure you have a decrease in GFR. That's going to limit the delivery of that active vitamin D to the PCT cells. Okay. And third thing is going to be your decrease in functional renal mass. Limits the production of 1-alpha-hydroxylase. Limit the production of 1-alpha-hydroxylase. So what did I mention all of this? So here again, in CKD, all you have is an earlier CKD, meaning earlier time, you will have increase in FGF, which I talked about, that is going to inhibit that 1-alpha-hydroxylase. Later on, you will have, in CKD, you already have a lower GFR. So you, although you have vitamin D, but it is not going to go on to the PCT where it does its action. Okay. Third thing is that with the CKD, you have decrease in functional mass of the renal functional mass. So when you decrease the functional mass, you're already decreasing the PCT, which is the 1-alpha-hydroxylase, which has the 1-alpha-hydroxylase cells. So that's also going to decrease. Okay. That's going to be pretty much what we have. And that is all. So one more, let's just talk about how vitamin D comes in. Although it's a biochem type thing, but since we are going in details here, so let's just go in a little bit deep dive into how vitamin D comes in. So you have a normal vitamin D metabolism. That's, if you want to open your biochem, that's going to be there. But here what happened, you have a UV, again, B rays. UVB rays are going to get on the skin, right, when you're in the sun. So there's a conversion of 7-D hydrocholesterol. Let me write it down. 7-D hydrocholesterol to vitamin D3. Vitamin D3, which is cholecalciferol. Cholecalciferol. That cholecalciferol, again, there are two ways that you can get this cholecalciferol. One, by the UVB rays. Second, by the dietary intake. Dietary intake will give you not only D3, but mostly D3, but also D2, vitamin D2, which is your ergocalciferol. Okay. So either D2, D3, no matter what you're getting, is vitamin D, right? That is going to cause, that is actually, first of all, is going to go to liver. When it goes to the liver, it is the liver is going to be the primary storage for the vitamin D3, which is called the calciferol. So primary stores D3. Let's just mention that. From there, the liver, there's an enzyme that is 25-hydroxylase. This enzyme here, 25-hydroxylase, will convert, will actually, because we said it's a storage, right? So it's going to send that 25-OHD3 to the kidneys when the 25-hydroxylase works on it. So 25-hydroxylase, when it is there, is going to send that stored vitamin D to the kidneys. While in the kidneys, that 25-OHD3 will convert into the active metabolite of vitamin D, which is 125-OHD2D3, which is 125-dihydroxy vitamin D3. Other name is calcitriol, D3-triol. And the enzyme we need is 1-alpha-hydroxylase, which is present in where? It is present in the PCT, proximal convoluted tubular. We would talk about that. I think it will come up where, or maybe in the kidneys, that there are specific cells, I think fibroblast cells, that produces this 1-alpha-hydroxylase. Okay. and we did talk about the everything else that is going to go on the bone and the kidney. I mean, in the bone, in the intestines, and cause the function. Okay, so let's review this part and move on to the next. So we not vitamin, UVB rays work on the skin, convert that 7 dehydroxycholesterol into vitamin D3, which is cholecalciferol. You also get that from diet, D3, and also D2. You also get that from diet. Now, an important point is no matter you get it from the UVB rays or the diet, it has to go to liver to get stored there. When it is stored, now if you when the 25 hydroxylase, again look at the name, 25 hydroxylase, 1-alpha hydroxylase, same enzyme. Whenever you see hydroxylase, this enzyme hydroxylase, you think about vitamin D. 25 is the one which converts, which sends that stored into the kidney, while the 1-alpha is the one which activates it from inactive to active calcitriol. Okay, and that is just going to work on its organs and eventual cause increase in calcium and phosphate. And that's pretty much it for PTH. Let's review it quickly and move on. PTH, important thing is, again, it's overall, it's going to cause increase in calcium. Overall, it's going to cause decrease in serum potassium, not potassium, phosphate, okay, phosphate. But high yield increases urine phosphate. High yield increases urine cyclic AMP. And why is this increasing cyclic AMP? Because when it is working on the kidneys, it works through G protein adenylate cyclase. It works through G coupled proteins, adenylate cyclase. So when the PTH works on a receptor, it works through this adenylate cyclase, causes increase in cyclic AMP that goes in urine. So you will see increase in urine, cyclic AMP. That just means that you have a lot of PTH. Okay. Second thing, you have increase in rank ligand, which binds to the rank and then stimulates the osteoclast. So PTH does not have a direct response on the osteoclast in turn. It stimulates osteoblast, which then in turn activates osteoclast. PTH is a phosphate trashing hormone, simple. PTH-RP, seen in malignancy squamous cells, RCC. Magnesium acts like, for example, low calcium. And low calcium, low magnesium stimulate PTH. High phosphate or very low magnesium decrease. Very low magnesium would decrease. Well, I think I said it opposite way. Let me say it one more time. Low calcium, low magnesium, both will stimulate PTH. Now, when you have a high phosphate, I mean, this is not for memorization. It should be a concept in the head, right? It should be a concept in the head. Low calcium, phosphate, high. Simple. Common causes of low magnesium, that's important. What are the low, for example, if you have low magnesium, the common causes are diarrhea, aminoglycosides, diuretics, alcohol use, all that can cause low magnesium, in turn causing increase in PTH, in turn causing high level of calcium in the blood, and low phosphate. Calcium is a major regulator of PTH release, simple. And we did talk about all of this and that. Okay, that's pretty much it for PTH. Okay, now what we're going to do is we're going to start with calcium homeostasis, simple. Okay, now let's talk about calcium homeostasis. Well, the calcium homeostasis, we have the plasma calcium. It exists in three forms. Important, okay? The first is your ionized or free, which is 45%. Wow. Which is the actual active form, right? Which is the free, ionized free, right? The other one is bound to the albumin. Now, whatever is bound is not active, so you have 40% of that. Wow. Then you have some calcium which are bound to anions, which is about 15%. So the only regulation here is this. So this ionized free calcium, it regulates the PTH, right? Okay, now let's look. So PTH, I mean, ionized free calcium is the primary regulator. Simple. Uh, Now, important thing is changes in the pH alters the changes in the pH would alter the PTH secretion, whereas changes in albumin concentration do not. Again, what did we say? We say when we have a change in a pH, it will alter PTH. Whereas when you change the albumin, it does not. Whereas changes in albumin concentration do not change the PTH secretion, which I guess is mentioned here, but we will see that. Okay, now let's read first here, the left side or right side. That's the calcium competes with hydrogen to bind to albumin. Important. So calcium is competing with what? Hydrogen, right? So when you have low hydrogens, that means you're freeing up more albumin. So albumin binds more calcium, simple. And that's going to cause decrease in ionization of the calcium. Decrease in ionized calcium, meaning decreased free calcium. And that's going to cause decreased calcium sign and symptoms, which are cramps, pain, paresthesias, carpal tunnel, spasms. Simple, right? But when you increase, uh, wait, that also decreases, that also increases the PTH. Again, let me recall the whole thing. Makes sense. It's a simple thing. That calcium and hydrogen, both of them are going to compete against what? One thing, albumin. So when you have low hydrogens, more albumin will bind to calcium. Simple. When the more albumin binds, you are essentially decreasing the free calcium. When you're decreasing free calcium, we said it is the primary regulator for PTH, so it's going to cause increase in PTH. Simple. Now, in other way, if we were to increase the hydrogens, now albumin will bind less calcium and more hydrogen, causing increased free calcium, causing decreased PTH. Simple. As seen in the picture, here you have a normal, you have, let's just write it down here. You have alkalemia, meaning you have increase in pH, meaning you have decrease in hydrogens. When you have decreased hydrogen, what is going to happen is you will cause the albumin to bind more calcium, and that is going to cause decrease in free calcium. So here you have more bound calcium, simple. And here you have more free calcium because in acidemia, and you can just read the above and it's the same as I explained. But if you, let's just actually go through it if somebody missed it. Okay, we have acidemia, for example. Acidemia is what? Low pH. Even if you don't remember, forget the low pH, just acidemia, meaning more hydrogens. More hydrogens are going to bound to what? Albumin. When they're bound to albumin, right? So there's going to be less calcium bound, meaning free calcium. Right there, free calcium. Simple. Okay, that's what we have. Okay, one other thing. Let's just mention it here. And that is that calcium and magnesium. Let me write it down here. So calcium and magnesium, they both interfere with QT intervals. Okay. So QT interval is increased with both. Increase meaning prolonged, just remember that. And QT interval will be decreased with both. Simple way, let me just erase this and make it a little simple. Simple way, when you have, just remember, when you have increase in calcium or magnesium, what's going to happen is going to increase the QT prolongation. And when you have decreased in this, it's going to decrease QT prolongation. Simple. Okay. And that is going to be all. One important high yield point again is going to be this point, that free ionized is only 45%. And this is the primary regulator. And remember, the hydrogen and calcium, they try to compete for albumin. The more it's bound, the more the calcium is bound to the albumin, the more, the less we will have the free calcium, right? The more is bound, so the less we have. So the less we have, the more PTH is going to be there. Okay, simple. And that is all for calcium homeostasis. Let's talk about calcitonin. Calcitonin, it's coming from the parafollicular C cells of the thyroid. So it's coming from the thyroid. Again, it's coming from thyroid, but which cells? Parafollicular. What about the follicular cells? Well, the T3, T4 thyroid comes from the follicular cells. So para, on the side of follicles, you have the parafollicular cells that releases the calcitonin. Now, we talked about how we need the calcium. Now, this is total different. It causes decreased bone resorption. So basically decreases serum calcium. So wait, let's talk about regulation first. When you have increase in serum calcium, it causes increase in calcitonin secretion. That increase in calcitonin causes decrease bone resorption. Okay. So calcitonin opposes the actions of PTH. Not important in normal high yield. It is not even important in normal calcium homeostasis, because we said normal calcium homeostasis is done by two things: PTH and vitamin D. Normal homeostasis. Calcitonin does what? It just tones down the serum calcium levels and keeps it in the bone. And what we do is we could use this for pharmacologic therapies for hypercalcemia. Otherwise, as you know, it has a very minimal role. So let's just take a look at its normal function again. Normal function is going to decrease. Let me write them down here. Decreases serum calcium, right? By inhibiting bone resorption. An increase in, if there is an increase in calcium in serum, it leads to increased calcium in urine. Okay, so that's only one thing. Second thing it can do is, if there is increase in calcium in serum, it causes increased calcium release in urine, okay, by inhibiting renal reabsorption of calcium and phosphate. So it inhibits the renal reabsorption. So more calcium goes out in the urine as a function of it. So let's take a look at this picture. So we have the calcium as green. In the peripheral, what do we have? Let's say we have increase in serum calcium. That leads to release of calcitonin from the parafollicular or C cells of the thyroid. Okay, because calcium binds to the receptors and causes increase in calcitonin. Increased calcitonin also inhibits the osteoclasts. Well, osteoclasts were doing the bone resorption, right? So it decreases the bone resorption. And when you decrease bone resorption, you're decreasing the calcium coming from the bone. Calcitonin lowers the serum calcium by inhibiting osteoclastic bone resorption. Okay, and that is there. So the thing that you can just remember is with the C's, you can say, okay, increased calcium leads to increased calcitonin. C for calcium, C for calcitonin. And calcitonin would just inhibit the osteoclasts directly, leading to decrease in calcium. Okay, and that's pretty much what we have for this one. Let's talk about glucagon before we finish this page. Okay. All right, now let's talk about glucagon. Glucagon is coming from the alpha cell of the pancreas. If you recall, we had the peripheral alpha cells, and in the middle, we had the beta cells. So it's coming from the periphery. It promotes, it has a job opposite to insulin. It promotes glycogenolysis, which is the so all it does is it's trying to keep glucose in blood. So the way it does it is by increasing glycogenolysis, breakdown of glycogen, gluconeogenesis, formation of glucose, lipolysis or lipolysis, breakdown of lipids, ketogenesis, formation of ketone bodies, which essentially all of that is elevates the blood sugar levels to maintain homeostasis when the blood stream glucose level falls too low, for example, in fasting state. So normally this guy comes in the fasting state, keeps the blood sugar level in homeostasis, meaning in normal levels. Regulation, it is secreted in response to hypoglycemia, and it is inhibited by insulin, amylin, somatostatin. Again, statin is the one which is somatostatin, right? Which inhibits the growth hormone, right? Hyperglycemia. Okay, again, it is secreted in response to hypoglycemia. Again, it is secreted when there is a hypoglycemia. It is inhibited when there is hyperglycemia. You eat a food, you're not in fasting state, you have glucose in the blood, you're going into hyperglycemia, you are going to inhibit glucagon. And who's going to come up? Second thing, insulin, to put that glucose back into the peripheral tissues. And that's all about glucagon. Let me see how many pages are left. We have insulin, very high yield, adrenal steroid, cortical hyperplasia, cortisol, and that's it. So 3 more pages. Okay, tell me, please do comment and let me know. Should we take a little break and continue with these 3 pages, 4 pages left for physiology, or should we call it a day and start tomorrow on this? Majority is gonna win, so do whatever you guys think. And while you guys vote, I'm just gonna turn on the timer. And I have a and also do let me know how was the mode of going through this. How did you guys like it? If there's anything you want to add or subtract.